I think we are all spending the lockdown very usefully. India has become the land of webinars. Every day we have about 5 to 7 webinars on various topics covering the length and breadth of ophthalmology. And today we have a very, very important webinar, which is Tamil Nadu PAN Ophthalmic Premier League, PAN OPL, a concept which has been started a few years back in the Tamil Nadu Ophthalmic Association conferences, and we have been continuing this for every conference as well. And more importantly, we have a very, very young team. The young team consisting of players from Coimbatore, Madurai, Chennai, and Salem from all over Tamil Nadu. And it's really a very young team, which is many of them first timers as far as OPL is concerned. And before we start the ball rolling, let me welcome and request Dr. Thangavelu, the dynamic president of Tamil Nadu Ophthalmic Association, to give the welcome speech and say a few words. Over to Dr. Thangavelu, please.
Morning, everyone. Welcome to the first PAN OPL. Beware the Ides of March. This is how the soothsayers want Julius Caesar. Now, when the whole world is like soothsayers trying to predict the future, I'm happy to be a part of this real-time interaction, and much more than that, to see so many enthusiastically participating and sharing your valuable knowledge and time. Apart from learning a lot of experts, like the football premier team, it is going to be fun, exciting, forgetting all our worries. Thanks to Dr. Mohan Rajan and his team for the initiation taken. We all know that Mohan is an expert in conducting Premier Leagues. His team has won a record number of times. Thanks to all the participants and the viewers. Thanks to Zivera Pharma for sponsoring this event. All the best to all the individuals and the team. I know that each and everyone has put in a lot of efforts to make this a grand success. Wish all the members and your loved ones good health, courage, and confidence that this crisis will also pass. We are all very fortunate. Don't forget, we have a very bright future. This is an opportunity for sharing, learning. It is an opportunity to come together, learn to work as a team, especially in situations like this. I am sure everyone here is a member of insurance schemes of our associations. This is one way of benefiting by sharing. There is no greater joy than sharing. Let's share. Thank one and all for the opportunity, for sharing your time and knowledge. Thank you, Mohan Rajan. Now I request Dr. Mohan Rajan take over the proceedings. Thank you very much. Thanks to everybody.
Thank you, Dr. Thangavelu, for the nice words of wisdom. I think it's very important for all of us to listen to the president of the Tamil Nadu Ophthalmic Association and make use of this webinars or the lockdown time very, very usefully as well. So most important is I want to introduce the judges, okay? Before we go on to the panelists will be introduced by Dr. Ravi Shankar, my co-moderator. So I am the moderator, Dr. Mohan Rajan, President-elect of TNOA. Along with me is co-moderator, Dr. Ravi Shankar, Senior Consultant Rajan Aikar, and also the member managing committee of TNOA. And along with us is Dr. Nivian, who's a match referee, who's going to take care of all of us as far as the timing is concerned, the questions from the audience is concerned. Okay? As you know, Nivian is the director of the MNI hospital and is a very, very dynamic, both anterior and posterior segment surgeon as well. More importantly, let me introduce the judges. Okay? The judges are the giants of ophthalmology as far as Tamil Nadu, not only Tamil Nadu, but India and the world is concerned. And we have none other than Dr. Madhivanan Natarajan, my guru, Dr. Madhivanan Natarajan, past president of TNOA, director of MNI hospital, who has really set trends as far as ophthalmology in this part of the world is concerned. And we have Dr. Madhivanan Natarajan as one of the judges. And along with Madhivanan Natarajan, we have Dr. Siddharthan, a very, very close friend, director of the TMSI Hospital, Salem, also a past president of TNOA, also very dynamic, both anterior and posterior segment surgeon, Dr. Siddharthan, and he's also going to be a judge as well. And of course, Dr. Thangavelu, who just gave the presidential address, the president of TNOA, who has really made a very, very huge mark as far as the TNOA is concerned. And he is also the director of MVI Hospital in Coimbatore. And then we have Dr. R.D. Ravindran. R.D. Ravindran, as you know, is the colossus of ophthalmology, and he's the medical director and of Aravind Eye Hospital, Madurai. He is the one who is actually the vision of Aravind Eye Hospital, Madurai. And we're very fortunate to have Dr. R.D.R. here amidst us and to share his expertise as well as be the judge for this TAN PAN OPL. And we have Dr. Panir Selvam from Arasan Eye Hospital, Erode. Arasan Eye Hospital is also a postgraduate institute of ophthalmology. Panir Selvam trains a lot of people. He's a very, very, dynamic, prolific cataract surgeon, and he's a good teacher, and he's also a past president of TNOA. Thank you, Panir Selvam. Welcome, Panir Selvam, for this wonderful TAN PAN OPL as judges. Okay, for the players and for the different teams, please take care of the judges if you want to win the prizes of different categories. The bribes can be in the form of either cash or even the PPE kits, masks, or even the goggles and the face shields. So whatever you want to give, please take care of the judges right away so that they will take care of you at the end of this OPL as well. Okay, and then before we go on to the program, let me request Dr. Ravi Shankar, my co-moderator, to introduce the panelists. We have an expert galaxy of panelists here. So the format of this OPL is slightly different. How different it is that every team, all the 4 players go in, number 1. And then after the end of the fourth, of team number 1, then we'll ask the panelists, okay, questions about each player. And we have got panelists from all the subspecialties, like cataract, cornea, refractive, glaucoma, retina, everything is there. Because each of these players, one of them will present on cataract, one of them on cornea, one of them on glaucoma, and one of them on retina as well. That is why it's called PAN Ophthalmic OPL. Okay, instead of only cataract OPL, we have divided this into subspecialties as well. So I request Dr. Ravi Shankar to introduce the expert panelists, please.
Very good morning, sir, and thanks for giving me the opportunity. The TAN PAN OPL 2020, and it's my pleasure to introduce the panelists to you today. The first panelist, Dr. Sujata Mohan, Executive Medical Director, Rajanaikar Hospital, and a senior cornea and refractive surgeon in the country today, and a former editor, the Tamil Nadu Journal of Ophthalmology. Thanks for being the panelist this morning, madam. Thanks and welcome. The second panelist would be Dr. Chitra Ramurthy, well known in the field of ophthalmology in this country, presently Chairman, Academic Research Committee, All India Institute of Ophthalmology, AOS. And she's one of the senior cornea and refractive surgeon from Eye Foundation, Coimbatore. Next in the panel, we have Dr. Pramod Bende, Head Retina Services, Shankar Netralaya. Thank you, sir. Thank you for being here. And he's a wonderful teacher. He's guided so many retinal surgeons in this country. Thank you. Next in the panel, it's Dr. Madhavan. Dr. Madhavan from Erode, wonderful surgeon, good clinician, having his good practice in Erode, and presently the Honorary Secretary, Tamil Nadu Ophthalmic Association. Thank you, sir. And next panelist is Dr. Murli Ariga, Senior Consultant Glaucomatologist from Swami Eye Clinic, Chennai, and also the Academic Director of MNI Hospital. Thank you, Dr. Murli Ariga, for joining us as the panelist. Next in the panel, last but not the least, Dr. Manoj Khatri, Senior Vitreoretina Surgeon and Head VR Services, Rajan Eye Care, and Director iDocs Eye Hospital, Chennai. Thank you once again for being the panel, and I'll come back with rules and regulations later. And back to Dr. Mohan Rajan, please. Thank you.
Thank you, Dr. Ravi Shankar. I think we are very fortunate to have an expert panel here, and panel from the various subspecialties of ophthalmology who are all very big stalwarts as far as the ophthalmology is concerned in this part of the world. And we have the rules and regulations of this OPL. Again, back to Dr. Ravi Shankar to give the rules and regulations as well as the prices categories as well.
Yes, sir. Thank you. There's no much of rules and regulations since it's a virtual meeting, and anyway, it's a lot of science and a lot of fun. We would promise that. And for the judges, kindly note there are 4 players per team. Each player will present a video of 4 minutes, not crossing 4 minutes. And the allotted time for the entire team is 16 minutes, 4 minutes. As Dr. Mohan Rajan told earlier, there'll be a grace of 1 minute.
1 minute.
And Dr. Nivian, please note that. And I would request the judges, there would be 10 marks to be allotted per video presentation, 10 marks. And all the 4 players, totally 40 marks per team. So judges, kindly note 40 marks per team. It's up to you to give what mark you require, you wanted to do. Depend upon how much they have sent you. I think by this time they must have, you check your wallets, you check your bank accounts. Is there anything good there? And you can do that. So ultimately the judge's decision would be final. And I request the players to accept it, and they are all stalwarts in the field of ophthalmology. So you need to accept they are the final results. And referee, Dr. Nivian Madhivanan, so smart, so sweet, sitting in front of us, looking bright, fresh. Nivi, and the timings, as I said, need not be very strict, but let it be 4 minutes. You have a timer, and you'll be informing the players at 3 minutes. And then once it finishes 4 minutes, they need to stop it. Judges will be noting that too.
Ravi, I would say, see, the total team will have 16 minutes. You don't have to inform at 3 minutes. The total team will have 16 minutes, with 1 minute to grace. So you don't have to inform them. So
okay, sir. Okay. Yeah. And coming back to the judges, there are 3 prize categories. And Dr. Mohan has decided after the lockdown, the trophies will reach the winners. So now you can just virtually hold it after you win it. As simple as that. And category number 1 would be the best team. It may be Madurai, Chennai, Coimbatore, or Salem, the best team. That's category 1 prize. Category 2 will be the best video presentation. It is a single player. It can be any team. It's a single player. Second, category 2 would be the best video presentation. And category 3 would be the best headgear. Whoever is wearing the attractive, good-looking headgear, that's category number 3. So thanks for giving me the opportunity to talk about the rules and regulations. Back to Dr. Mohan Rajan.
Thank you, Dr. Ravishankar. Once again, thanks, Nivian, also for being here. I think Nivian is a great support for all of us. And I want 1 or 2 words from each of the judges. So you're starting with Dr. Madhivanan. Madhivanan, can you just come online and say a few words, and then we can start the program.
Hi, Morgan. Can you hear me?
Yes, Madhi.
Yes. This is really a out-of-the-box type of program that we are having. We have been listening to so many webinars, but I think this will be the first of its kind. And yes. I really hope that we all really enjoy ourselves. Thank you, Mohan, for arranging such a wonderful program. Yeah. Thank you.
Thank you. I think it's the first of its kind, the OPL being arranged on a webinar, because very difficult to arrange the OPL on a virtual platform. And this is the first time we are trying it out. Let's have 1 or 2 words from Dr. Siddharthan, please. Siddharthan, are you online?
Sir, Siddharthan said he will connect in some time. He's having some difficulty with the connection.
No problem. Dr. Thangavelu.
Yeah, well organized, Mohan. I'll do my best as a judge. I'll give a little preference for my team, Coimbatore team. That's all.
You can't do that, sir.
Judges, please kindly send your NEFT transfer numbers to the respective players, so that the bank accounts are taken care of. Sir, 1 or 2 words from Dr. RDR, please. RDR, sir.
Yeah, thanks TNOA and Mohan for this opportunity to be part of this first webinar from TNOA. I mean, it's what is happening is a very testing time for all of us. And it's also a time we all have to stay hopeful and very positive. And fortunately, right from day 1 of lockdown, something or other happening to keep us all busy academically, and to keep us motivated, either from all of us, all the friends and AAOS. And also thank TNOA for keeping in touch with the members through their communications and various guidelines. And today's OPL under Mohan's leadership is going to be really fun. Just waiting to hear it, see it, and enjoy it. Thanks, thanks everybody for this opportunity.
Thank you very much, sir, Dr. RDR, sir, and Dr. Paneerselvam.
Good morning.
Paneer, yeah.
Thanks for inviting me. It's very nice of you. And I also thank Ravi Shankar. When he invited me, I was wondering, one more webinar, what is that? But luckily, it is going to be different. And I'm as curious as everybody how it's going to be. All the best.
Okay.
Thank you.
Now we have the teams, and all of them are really geared up in the form of headgears. And as you know, as I told you, as Ravi Shankar told you, we've got a special category of prize for the best headgear as well. So let me introduce the first team, the Coimbatore Challengers. Give a big hand for Coimbatore Challengers. And we have none other than Dr. J.K. Reddy. J.K. Reddy, as you all know, is a very innovative guy from Shankara Eye Hospital, Coimbatore. Then we have Dr. Atik Sheikh, who was migrated from Chennai to Coimbatore because of the COVID. And he is also director of Fatima Eye Clinic in Chennai. He is the chairman scientific committee for the Madras Icon Conference. And a very, very good phaco surgeon. Dr. Ganesh Raman, who is a top glaucoma guy from Aravind, Coimbatore. And Dr. Saravanan, who is the top VR guy from Aravind, Coimbatore as well. So you have got a fantastic team, Coimbatore Challengers. Over to Dr. J.K. Reddy. Go ahead. The time starts now.
Come on, JK.
JK.
Come on, JK. All the best.
All the best, JK.
Yourself. JK sir, unmute yourself.
Unmute yourself and start. Please unmute yourself. Players, all others can mute.
JK, please unmute yourself.
Yes, did it.
Yes, yes, be a little louder.
Yes.
Be a little louder.
All the best, JK.
Yes, sir. So welcome to the OPL, and it's from Coimbatore, land of Adiyogi. And what I'm going to present is not a very complicated thing like what this picture shows. It's a very simple solution for a very complex problem. And the first hand ever reported, or it's a very simple and it's a very super technique and it's spectacular results. So this is a 20 years old patient reported to us with defective vision of 6 months. He can't see anything with VKC from childhood, on treatment on and off for 15 years. And this is the other eye of the patient. That eye vision is counting fingers close to face, and this eye vision is around 624. So what we have to do it, this patient is referred for, this is the both eyes of a patient, 20 years old, virtually blind from allergic conjunctivitis, a disease we generally regard as a non-blinding disease, but we have a patient who is practically blind. So this is referred for further management. So what we did is we did a OCT of the right eye. What we found is the pannus is above the cornea. The cornea you can see very clear below the pannus. There is a fibrovascular pannus above the cornea, 260 microns, and below there is a clear cornea. So what's our plan? The 747 is the corneal thickness, 500 cornea, 247 is a pannus. Simple, we can access the pannus. And healing, we can use the AMG for proper healing, but the question is how to prevent fibrovascular pannus. That is a big question left in our mind. So we took up this case and did a 360 degrees periotomy. If you see carefully, you can still see some limbus stem cells in the inferiorly, and very carefully we removed all the pannus or the cornea because the surface should be very regular. If you produce irregular surface, there will be compromised vision. This is the AMG. Of course, this is the simplest part. Then what we did is we took a stem cells from cadaver eye. So instead of, this is select procedure as described by Dr. Virender Sangwan from LUPI, but here we took a almost 180 degrees from the donor cornea instead of 3 millimeters because we have a lot of cells, and we replaced them at the limbus. Exactly, we searched all the literature. There is nowhere any case reported anywhere in the world as far as my limited search is going on. There may be a report, but I'm not able to find. Then as routine, no systemic steroids, only topical medication. This is after 6 months of surgery, 6-12 unaided vision, and patient had a correctable vision up to 6/9. Thank you for watching.
Next player.
Superb, JK.
Superb,
No,
superb.
don't talk in between, please. Next player.
Yeah, I had to stop sharing, sir.
Stop sharing. Next player. Atik Sheikh.
आप हमको ही भेजें. Thank you. Thank you.
A testing time needs a superhero. All of us are superheroes at this juncture. Surgical complications happen to all surgeons, and the way it is managed differentiates a great surgeon from a simple one. When you have a complication, you need to stay calm and feel responsible. நமக்கு முன்னாடி என்ன நின்னு தோத்துட்ட உனக்கு கதை முடிஞ்சிச்சுன்னு சொன்னாலும் நம்மளா ஒத்துக்கிற வரைக்கும் நமக்கு அந்த தோல்வி வர்றது கிடையாது. Never ever give up. This was a case where we had a hypermature cataract. We started to do a routine phacoemulsification, injected high molecular weight viscoelastic, and the rhexis is being done. We were able to get a fairly decent rhexis without the help of the current generation gadgets. And the secret here is let out some amount of viscoelastic and do gentle, very little hydrodissection because there is not much of cortex left and mainly the nucleus. And then the core and a little bit of cortex is debulked. And then we start to go ahead with the phaco. Choosing the right phaco tip in these cases is important. And going down and cracking the posterior plate is even more important. The first crack is done. And after doing the second crack, we noticed that the bag was a little unstable. So the long chopper comes out and in goes in the shorter chopper. The purpose of the short chopper is the chances of posterior capsule rupture is less. Now we notice that from the temporal side, some amount of zonules have given way. So we sought the help of capsular hooks for this case. So make 2 short entries and then goes in the capsular bag hooks. These hooks not only stabilize the capsular bag, but also helps to keep the pupil at bay. And then we use the capsular tension ring to provide support to the capsular bag. And then the phaco parameters need to be changed. We need to lower our aspiration flow rate and vacuum so that there is less turbulence. And then you need to ensure that phaco is done right in the center and not in the periphery with slightly lower parameters. You can notice that there's not much of vitreous, just very little through the wound. So with diluted triamcinolone acetonide, we remove the vitreous. And now the capsular hook is brought out and a single piece lens is implanted into the capsular bag with the haptic supporting the area of zonular dehiscence. Now the vitrectomy is completed and you can see there is no vitreous. When you have a surgical complication, do not panic. வாழ்க்கையில என்ன நடந்தாலும் பயம் இருக்கலாம், ஆனா பயமே வாழ்க்கையா இருக்கக்கூடாது. In this juncture and always, we need superheroes to save our patient and the world. All of us are responsible. With great power comes great responsibility. At this juncture of COVID, not only Spider-Man, all of us are Spider-Man. We need to save the world. Surgeon's mantra is we need to stay calm and never ever give up. Thank you.
Over to Ganesh Ram.
Sir, thank you.
Screen.
Thank you for the opportunity. Now, with this COVID, we all have a deficiency of sclera available with us. So this video will show you what other things you can do, what ways you can do to, from the beginning. Can you see the video?
Yes.
Okay, thanks.
No audio.
No audio?
Audio,
No audio.
you have to give audio. Why don't you give audio? Why don't you talk? Ganesh.
Okay, so this is a patient with a long time back ECC triple done, and he had a cystic bleb right on the limbus. So we were wondering what to do. We excised the bleb around the ring of steel. You can see that, and the necrotic tissue has been removed, and we're undermining the bleb here now to advance the conjunctiva. And if you put a very full thickness patch graft, it will increase the profile at the limbus. It will be a huge mass. And basically, he came to us for both aesthetic appearance as well as cosmetic purpose. So we would, give him back the same thing. So we decided to do a bleb revision with a difference. So this is a hinge flap. The flap is square shaped. It just covers the defect at the limbus, and it's taken forward right up to the limbus on the cornea. And then this is a suture at the limbus, with the help of the cornea to anchor the turn part of the sclera. So it's a partial thickness, maintain a low profile, and you're using the patient's own tissue, so you don't have to hunt around for any alternative. And once you have opposed it, we sort of apply a buttress suture. You can see here. It's a suture which opposes the sclera firmly to the.
Ganesh, reduce the audio in the video. Yeah, fine. Your audio, please. Your voice.
Yeah. So we have opposed it. Now we'll have an anchor suture at the limbus. So if you have, you don't have sclera, you can always work around ways of doing this. So the indications for bleb revision: recurrent blebitis, endophthalmitis, recurrent blebs with symptoms. Thank you very much.
Thank you very much, Ganesh. We go on to the next, Saravanan. No audio, Saravanan. We are not able to hear. Saravanan, please unmute yourselves.
Yeah, but the video is playing, sir.
Video is playing, and you can give the audio. You can talk.
Okay.
As retinal surgeons,
So as retinal surgeons, we just hate holes.
I'm just going to show various
I'm just showing various events where we're just stuffing them tight.
As you can see in this funny video.
This funny video, you can see that the boy who's jumping around, if there's a hole, it can lead to grave consequences.
Now, if you can reduce that audio, there on the video, it'll be fine. You can talk.
Setup surrounding the hole.
Are you able to hear the video of the audio?
Yeah. You can do that also. Yes.
Like the petals of a flower, and then stuffing it inside the hole to aid in macular hole closure. After stuffing the petals of the ileum into the hole, fluid exchange is done and gas is injected to aid closure. This is another instance of a failed macular hole in which, rather than stuffing the petals into the hole, they're just creating a small hinged ileum flap and closing the macular hole like a trap door. This flap will be closing the macular hole like a lid from above. Large holes, not only in the road, but in the macula, can lead to grievous outcomes. In this case of a failed macular hole, we are trying to harvest the anterior lens capsule of the same patient and then placing it over the macular hole and covering it like a lid, and then help in successful closure of the macula. This is another case of a failed macular hole in a pseudophakic patient where we are harvesting the posterior lens capsule and using it to cover the macular hole and help in successful closure of the hole. Large holes can swallow you as a whole. It's a case of a large failed macular hole where the edges were lifted from the surface of the RPE. So we had to mobilize retinal autograft from the superior retina and mobilize it under the cover of PFCL and stuff it under the macular hole to aid in successful hole closure. One more problem with holes is that they can leak, leading to a different set of holes, as you can see in this funny video. So we have our own MC to close these holes. This is a case of an optic disc pit with serous maculopathy. Here we are using the ILM as our MC, and we are doing a fovea sparing ILM peel, and then this hinged ILM flap is then mobilized and stuffed into the ONH pit to close it and stop the leakage and lead to normalization of the macula. The stuffing of the ILM is done under air to keep the flap in place. We go further. She asked me where my money is. घर में रखिए MC हमेशा. Our second MC is the sclera. In this patient with the ONH pit with serous maculopathy, we are mobilizing the sclera from the influential quadrant and cutting it and shaping it to the required size depending on the size of the ONH pit. And then this is placed and stuffed on into the ONH pit and leading to resolution of the serous maculopathy. 8 holes, just stuff them tight.
Sir, bang on time. 16.
Okay. Okay. Thank you, Saravanan. Thank you, Coimbatore Challengers, for the wonderful presentation. I think you had the entire spectrum of ophthalmology, starting from cornea, cataract, and then glaucoma, and then the retina. Fantastic surgeries and fantastic videos as well. And J.K. Reddy, I just wanted to ask you, you showed on cornea, pristine cornea post-operatively. Is it the same patient?
Yes, sir. I'm not from Coimbatore.
No, I just wanted this. I was kidding, but all the presentation is so good. Before we go on to the panelists, I think the panelists, we have got an expert panelist here. Over to Dr. Chitra and Dr. Sujata and Dr. Madhavan and Dr. Pramod and Manoj Khatri as well. And Chitra and Sujata and Madhavan, I want to know what is your take on J.K. Reddy's case as well as the cataract by Dr. Atik. And if you want to ask any questions to any of the players, you are welcome. Starting from Chitra and then Sujata and then Madhavan and then Pramod Bende, Manoj Khatri.
Actually, I think that was the J.K. Reddy's.
1 minute. Chitra can talk and then Sujata can talk.
Why can't I talk first?
Sorry, Sujata, sorry. Actually, Atik, I felt your surgery was so well done and the whole show was good. But it's just that it was an intermittent hard cataract. So probably, I would have also been a little cautious of creating a smaller excess and then going on to make it enlarged. Then the second thing was, you did mention about placing a CTR, but I saw the capsular hooks and you going on to the surgery. My thought was that I would prefer to place the CTR first, and then I would go and put my hooks and go on with the careful surgery.
He did.
Okay, you placed the CTR before you placed your hooks or after that?
After the hooks.
After the hook, ma'am.
I think you are doing, yeah, after the hooks. Okay. Right.
Yes. So that was the question for, and for Ganesh Raman, I had one question. You did a great job of covering up that area of which was cosmetically not okay, but don't you think you had weakened this part of the sclera by taking just covering it up with conjunctiva? You think there would not be, after all, this is a glaucomatous eye. Was that the way to have handled this moment? I wanted your answer on that.
Definitely, madam. That thought occurred to me while doing surgery also. The thing was that whatever the surgeon had done previously, it was all done at the limbus. So the posterior area was not affected. If he had used mitomycin C or if he had made a deficiency, it would not, the activity was not there at the posterior. The posterior was, especially 2 millimeters on the limbus, it was all very clear, very good sclera. So, if you put one more patch graft, you have the same problem, different cosmetically. So this appeared to be, especially at the limbus, you may have to do a banana graft or something like that with a corneoscleral button, like that component. So that becomes very difficult. So just slight rotation. I may not have used a full thickness, so to say partial thickness. I would have used only maybe 1/3 of the sclera. The remaining would be sufficient to manage the posterior part.
Chitra, any other questions? We'll go on to Sujata.
Yes.
I want to congratulate J.K. Reddy on the excellent presentation. I think this is a very well described technique, but he has done it with the cadaver eye and shown excellent success. The only thing is, when you're using a cadaverized stem cell, you normally the rule is that you have to use some immunosuppression. Otherwise, they do not work, and it's quite surprising that he said that he's not used any immunosuppression. So that's the one question I have for J.K. Reddy. And I think for Atik, it was a fantastic presentation, and I think he took all the right steps. He put the he used the hooks, then put the CTR, and the steps of the surgery were very well done. And the most important thing is when you're able to achieve a very good rhexis, in the first place is, there's no need for us to go for a small one then expand it, as Chitra said. So that is for Atik. And for the glaucoma case, my only concern, like Chitra said, was why not use a free scleral graft? That would have been much better than using the patient's own eye, where there's a possibility the melt can happen again in the area where you're dissecting. So the same concern like what Chitra was saying, that was my concern on that. And for the last retina case, I was just wondering, can you use a fibrin glue there to put the sclera? Can you to stick the sclera? That is one question I wanted to ask the retina people, because we're using that liberally. And I've also used in patients with where there's a bleb leak, I've used fibrin glue. And though it goes inside the anterior chamber, it is totally doesn't react. And after some time, it gets absorbed. So can that be also used in the retina, inside the vitreous? These are the questions I have.
Ganesh, sorry, Saravanan, can you answer that question?
Yes, sir. Fibrin glue can be used, but just like blood. Dr. Meena from Trivandrum, she has given a lot of success with autologous blood. Instead of fibrin glue, she has used autologous blood, which is less inflammatory, and it's from the patient itself, harvested from the patient itself. So both sort of serve the same function. So I would prefer autologous blood compared to fibrin glue.
Okay.
Yeah. Very nice comments, Sujata. And let's go on to Dr. Madhavan. Before we go on to Dr. Madhavan, I just want to know from Chitra and Sujata, as well as the other panelists, and also from Atik, whether you could have put a multi-piece lens instead of single-piece lens in that particular case.
Yes, it definitely gives that extra stability to the bag.
Yeah.
I would look at it as the hook, CTR, and a multi-piece would is exact for that small amount of dialysis.
Absolutely. That's what I also felt. I would have put multi-piece lens.
The dialysis was too small, and I don't think really going to make much of a difference.
Because
if you have pretty large dialysis, then you're putting a multi-piece lens would really have an additional support. In which case, CTR is not anyway going to work, and you have to use a Sioni ring or something like that.
So some of these are progressive dialysis. It's not just what you see on the table. So as much support which you could give to that area, sometimes vitreous could also present. Actually, the way that area of dialysis gaped, I thought that vitreous is also pushing up in that area. But thankfully, just the way he finished it, it did very well. And it was a moderately hard cataract. So I am all for a 3-piece only in these situations.
MR sir, there's a general question for Pramod Bende sir and Saravanan sir regarding
Yeah.
the hole closures. They wanted to know what is the correlation between the closure of the hole and the visual recovery in these various techniques.
Nivian, we'll come back to the audience question a little later. I want to complete the panelists.
Oh, okay, sir.
Okay. Madhavan, you have anything to say?
No, I just congratulate the team, and we have begun the OPL in right earnest. And thank you for a great beginning.
Thank you very much. And Pramod and Manoj, you have to comment on the retina cases now.
Well, I think I congratulate all the presenters. I think excellent presentation. I think they chose their selected case. As far as glaucoma case is a flap, scleral flap, I think this is one of the accepted even modality of treatment, rotational flap or inverse flap, particularly when you're dealing with a staphylomas. We routinely do that, particularly when they're having a shortage of sclera, and I think is well accepted. So I think should not be issue. Rest of the sclera, if is healthy, it generally holds on very well. Coming back to retina case, what Saravanan has shown, he has shown all possible options what you have as far as macular hole surgery and what you describe techniques are there. But that what indicate that we still not sure. When you have multiple options, then we know that no option is ideal. Okay. So personally, I think I'm not in a favor of capsule or sclera or other things. And now we all know stuffing probably is an issue. What we want is a cover the hole from ILM, and that is also not necessary in every case. Particularly larger holes are okay, and maybe probably you can put inverse flap or multiple flaps like a flower petal. But stuffing, we know now because it hampers closure. Though on OCT you may see that hole is closed anatomically, but probably generally usually visual outcome is not that great because due to stuffing, because it doesn't allow retinal tissue to come close together.
Yeah, thanks, Pramod. Manoj,
yes, sir. I totally agree with PV sir's comments, and as we have seen, even in the cases post-operatively where retinochoroidal transplantation has been done, the visual acuity gain is not that much. So we should be very, very careful in selecting these patients. Maybe in one-eyed patients, we can surely try this technique. And also stuffing, sometimes it works, sometimes it doesn't work. So just covering the hole with the ILM flap gives the same functional result what we are going to achieve with the stuffing. So that should be the it kept in mind.
No, I want
Thank
to.
You, but,
yeah. So thanks, Manoj.
Yeah, but excellent presentations from everyone.
Thank you, Manoj. Anything else? I want to ask a question to Pramod, Manoj, as well as Saravanan in this group. Is that what is your treatment, what you call protocol for optic disc pit with CSR? Do you just do ILM peeling?
Yes, best is to go for I feel from my experience, best is to go for a scleral graft, but it is a tissue which is harvested from the outside the eye. So second best is I feel ILM flap. Plain ILM peeling or gas or laser is not that very successful. My first choice is always scleral graft. Second choice is ILM graft.
Pramod, yours?
Probably I will be more conservative to start with because we know this optic pit. Generally, they come with a fluctuating vision. Sometimes a fluid also fluctuating. Sometimes is there, sometimes is not there. So I would like to start with a simpler thing. Maybe probably still I would do laser to start with. If it doesn't work, then go for vitrectomy. And yes, fovea sparing ILM peel, which the flap maybe I will reflect over the pit. Coming to about fibrin glue. Yes, it will temporarily close, but as we know, glue get absorbed. Probably it will open up pit later on again. So what Saravanan says, I agree with that. But flap probably will be an option if regular laser and maybe air bubble doesn't work.
Yeah, Manoj, yours take on that.
Yes, sir. In this, there is no frank fluid like a CSR. There is a splitting of retinal layer. So that has to be kept in mind. So the splitting happens at the inner retina as well as an outer retina. So the case selection becomes very, very important. And if given a choice for surgery, I will always prefer a fovea sparing ILM flap and lift that flap over the optic disc pit rather than doing a scleral stuffing in these patients.
I think we have done laser for a couple of patients. They have done well.
Yes. laser is there, but again, laser becomes a destructive procedure. So we tend to avoid that. Even if you're doing the laser, just do it along the edge of the optic disc and not the entire disc, what we used to do in olden days.
What about subthreshold?
Not sure about threshold, but you can use a a red laser, so that will not cause damage to nerve fiber layer, and very, very light burn.
Okay.
Very light.
Okay, since we are running short of time, any other questions from any other panelists? Chitra?
Can I interrupt with your permission, sir?
Yes, sir. We will go on to the audience after that.
One quick word from Dr. Murli Ariga. He's a panelist for glaucoma.
I'm sorry, I
have not
forgot.
taken his word.
I forgot. Sorry, sir. Sorry.
Dr. Murli Ariga for a glaucoma case, please.
Yeah, Murli. I'm sorry, Murli. Sir, yeah, I forgot Murli. Yeah. Murli.
No problem at all. I'm so engrossed. No problem at all. I'm so engrossed in the presentation that I think it's worth listening than commenting. Anyway, I think all the presentations were good, and I think both the cornea and the cataract case were really excellent. I think he's managed it very well. And the glaucoma case also, I think, is reasonably straightforward for people who do these bleb repairs. I think we do it all the time. We either use cornea, we use sclera, we use hinged, and we take flaps from different parts of the eye as long as the sclera is healthy. I think Ganesh's technique is quite a well-accepted technique. There's no problem with that. With the retina, I think I'm all at sea and as confused as the person who's looking at the closet and looking at the leaking water. I didn't understand head or tail of what
Murli, what is your choice for bleb revision? Murli? Murli is online?
Signal has got cut, sir.
Okay, Murli, Murli? Okay, Nivian, quickly go on to the questions from the audience.
No, sir, no more questions. That was the only question, sir. We'll move on to the next team, sir.
We'll go on to the next team. Okay, we'll have the judges comments later. We'll go on to the next team, the Madurai team. Introduction of the Madurai team by Dr. Ravi Shankar.
Thank you once again, and it's my pleasure to introduce the Madurai team. They are the Madurai Monsters. So they are ready to present here. Leading the show is Dr. Sriram Gopal, leading anterior segment and posterior segment surgeon from Trichy, and presently known as a trauma consultant in that belt. Nivi will talk about it later. They call him a trauma consultant over there. And we have Kaushal Ram, a prolific vitreoretinal surgeon who will be handling a retina case now with us. And we have Dr. Seema Ramakrishnan, who's a glaucoma consultant from Arvind. She would be discussing on a glaucoma case now. And last but not the least, Dr. Prasanna Venkatesh from the Mahatma family Trichy, son of Dr. Ramesh. And thank you, ladies and gentlemen, for taking up this OPL with you all. And there comes Madurai Monsters to you.
Okay, I'm sharing my screen.
மச்சான் பேரு மதுரை நீ நின்னு பாரு எதிரே மச்சான் பேரு மதுரை நீ நின்னு பாரு எதிரே.
This video is meant for entertainment only, not to hurt anyone. World of refractory glaucoma.
இங்க நம்ம சத்தம் மட்டும் தான் கேட்கும். நம்மளை எதிர்த்து குரல் கொடுக்க இங்க யாருமே இல்லை.
May I come in?
ஒரு பெரிய கேங்ஸ்டர்.
கேங்க கூட்டிட்டு வரவன் கேங்ஸ்டர், ஒத்தையா வரவன் மான்ஸ்டர்.
Madurai Monsters presents Cyclo G6, an innovative cyclophotocoagulation learning curve for neophytes. Cyclo G6 versus trabeculectomy. Traditional diode cyclophotocoagulation destroys the ciliary body, reducing aqueous formation. This is a Miyake apple view of the traditional diode cyclophotocoagulation principle of the continuous wave presenting as a pop sound during procedure. One can appreciate the amount of traction on the iris caused by thermal energy.
ஒரே ஒரு பாம் 28 கிலோமீட்டர் க்ளோஸ். அப்புறம் வெறும் ஜாமரத்து நெத்தியில போயிட்டு மணி ஆடிட்டு போக வேண்டியதான்.
நான் செவனேன்னா போய்க்கிருந்தேன். யாரு வம்பு தும்புக்காச்சும் போனனா? கௌரவம்னு என் கௌரவத்தையே ஆரம்பிச்சிட்டீங்களா?
With micropulse technology, the continuous wave is broken into micropulses, thus the thermal buildup is reduced. With continuous wave technology, the total on time is 100%, that is, the duty cycle is 100%. Whereas with micropulse technology, the duty cycle is 31.3%, that is, it is on for 0.5 milliseconds and off for 1.1 milliseconds.
I know.
What, yeah?
I know.
I am your best friend.
Okay,
Please?
okay.
The procedure is done by sweeping the probe around one hemisphere for 80 seconds, avoiding the 3 o'clock and 9 o'clock position. The mechanism of action is more of a cyclomodulation where the ciliary body phase and the trabecular meshwork is remodeled. Each hemisphere is treated for 80 seconds. It is a non-incisional laser with a favorable safety profile and retreatment can be performed as early as 6 weeks. Before micropulse.
இப்போ என்ன செய்வீங்க? இப்போ என்ன செய்வீங்க?
யார் சாமி இவன்? எங்கிருந்து வந்திருக்கான்?
Can Cyclo be performed as a primary surgery? Yes. Can it match the performance of trabeculectomy? It's too early to say.
இது என்ன பிரமாதம்? இதை விட பெசலைட் ஒன்னு இருக்கு.
If Nasamani was your trabeculectomy trainer.
டேய் மெல்ல என்ன செவருக்கு வலிக்கும். ஏமாத்தோடா பரதேசி. ஐயோ.
In situations where there was a deep irregular flap taken or when there was a uveal show during lifting the flap performed by a neophyte surgeon, if Nasamani was your trainer, then you would be putting him under tremendous stress as seen in this video. But I was fortunate enough to have the best in the business, my mentor and chief, Dr. Satyan Parthasarathi, who guided me in doing the trabeculectomy steps in the right way. Thank you, sir. Last but not least, all, please do stay safe. Thank you for giving me this opportunity.
Okay, we move on to the next video.
Second case for my team, MADURAI Monsters. I present the treatment of a large superior giant retinal tab with dislocated nucleus. A 20-year-old boy who presented with defective vision was found to have a superior GRT confirmed by ultrasound. He was posted for a 3-port pars plana vitrectomy with lensectomy and settling the GRT. A 3-port vitrectomy was done. The nucleus was found to be dislocated. A limbal section was made anticipating the nucleus would be large.
The video is not seen, man.
The dislocated nucleus was found to lie on the flap of the retina. It was initially brought anteriorly and delivered by the limbal section. The 3-port pars plana vitrectomy was continued. The anterior vitrectomy was done. You can see that the entire flap of GRT was unrolled and lying on the inferior retina. The vitreous was removed along the anterior edge of the tab. I used my third hand, the perfluorocarbon liquid, to open the flap of the retina, which is crumpled and lying inferiorly. PFCL is injected beneath the edge of the flap, and you can see beautifully how the flap is getting unrolled. Slowly, you can see that the view of the optic disc becomes more clearer. The superior flap is opened up. A lot of inferior vitreous is there. Vitrectomy is done inferiorly. The cuff of vitreous is removed. is done along the anterior edge of the flap. The entire anterior edge of the flap, which is spanning close to 6 to 7 clock hours, is endodiathermized. More perfluorocarbon liquid is injected, and you can see that the entire view becomes clearer. Endolaser is done 360 degrees from the equator and extending anteriorly. And then the most important step, a direct perfluorocarbon liquid silicone oil exchange. You can see the assistant is injecting silicone oil and closely the surgeon is removing the perfluorocarbon liquid, making sure that the entire eye is replaced by silicone oil. And the flap remains intact in its original position. There is no slippage. The retina remains well attached. The ports are closed. You can see a well attached retina under silicone oil with the vision improving to 636. Inferior laser marks a few subretinal band inferiorly, but is covered by laser and so the take-home message is anything is possible. A crumpled superior GRT was well attached with successful surgery. I thank you once again.
மதுரைக்கு போகாதடி அங்க மல்லிப்பூ கண்ண வைக்கும் தஞ்சாவூர் போகாதடி தல ஆட்டாம பொம்மை நிக்கும்
ஒரு கதை சொல்லிட்டேன் சார்.
நடந்தது என்ன? The story begins in the year 1992. A 29-year-old male from Rajapalayam, patient of Madurai Pakkandan sir, bilateral pellucid marginal degeneration, presented with right eye acute eye drops. He underwent a beautiful PKP performed by our cornea guru, Professor M. Srinivasan sir. And by the grace of Madurai Meenakshi Amman, the graft remained clear for over 2.5 decades. But one fine day after 27 years,
Akira, I'm not taking.
He presented with sudden fall in vision in the same eye, counting fingers at 1 meter. At first glance, it would have looked like an episode of acute graft rejection. The graft was edematous except for the inferior 1/4. Something did not make sense. After deturgicing the cornea with sterile topical glycerine, we found an unexpected culprit. A spontaneous Descemet's membrane detachment of the PKP graft decades after initial surgery, an extremely rare occurrence. Anterior segment OCT showed a DM detachment spanning the entire graft from nasal to temporal graft host junction. The patient had already been advised a regraft DMEC elsewhere for graft failure. And then, after 2 months of having a detached Descemet's membrane, the patient came to me. கருவியினால் நான் கருவிழிக்காகவே நான். But complex problems many times have simple solutions.
सर मेरा एक सवाल है सर. सर स्पेस में फाउंटेन पेन बॉल पेन चलता नहीं है तो एस्ट्रोनॉट्स ने पेंसिल का इस्तेमाल क्यों नहीं किया? लाखों डॉलर बच जाते सर.
We planned a gas decimetopexy with 20% isoexpansile concentration of sulfur hexafluoride. The only catch was the interim period of 2 months. Was the DM fibrosed? Not clinically. Would the quality of supradecimetic fluid be amenable to drainage by decimetopexy alone? Questionable. So we decided to add a supradecimetic venting incision over the site of maximum detachment. A short stab wound was made in the stroma after debriding the epithelium, akin to the brave slash in Big Bubble Dog. Fluid started egressing immediately and continued as the SF6 tamponade was given. After 1 week of surgery, the graft edema had completely cleared and the Descemet's membrane was well attached on OCT. The patient is maintaining 612 best corrected visual acuity after 6 months.
Veda, sir.
మగారాణి మంగమ్మకు జాతిదా మస్తు జాతిదా ఒడి మధురకార మనసు వచ్చా నాస్తిదా మస్తు నాస్తి.
Guy who gave me a tough time. So I didn't want the audience to have the horrible experience of seeing me doing a phaco surgery. So I thought I'll present this. Okay, guys.
Hey, very good.
And this is our headgear.
Incredible stuff from Madurai Monsters.
Hey, and we will got masters. Hey, come on, guys.
Sriram,
Sir.
Congratulations for the wonderful presentation. Incredible stuff. And before we go on to the panelists, I would like to ask Sriram,
sir,
what case was that exactly?
Which one, sir? The last one.
What you presented?
Sir, I'll tell it in a language you will understand. If you have a Murungaka Kumar, I have a Mullu Murugan.
Murunka Muttu.
Okay. If you have a Murunka Muttu, I have a Mullu Murugan also.
Very good. Excellent. Anyway, very good. We'll go on to the panelists. Let me probably call Murli Ariga first on this panel this time before I forget him. Murli?
Yeah, I'm here. Yeah.
Please comment on the.
Seen better.
Please comment on the first presentation made by Dr. Prasanna on the micropulse G6.
Yes, yeah, I was actually quite confused. A lot of entertainment there. Where was the glaucoma is what I was wondering.
That was all.
But actually, I could make out there's something about glaucoma going on. He showed some Rajinikanth and some other videos. And I was trying to figure out the glaucoma there, but anyway, it was nice. And I saw that hammer dropping on his head. So that is, I think, like the laser he was trying to do. So the new laser is somewhat like that. And it can be done, of course, in seeing eyes, but you really have to be careful and you can't compare it with trabeculectomy in all cases. So I think the micropulse laser has to be done with a lot of caution. You can't do it for everybody. And maybe it's particularly useful for seeing eyes with moderate and advanced glaucoma. You would really dread to do a trabeculectomy. So micropulse has a role, but I think it has to, there is a learning curve and has to be done with caution by somebody who does it regularly, not to be taken like.
Okay. Thanks, Murli. I want comments from Sujata and Chitra on this.
I think Prasanna's
all the presenters.
Prasanna's case was very entertaining. And I think probably what he wanted to convey was it is something which is very new, micropulse, which is very new, and it's a good substitute for patients who cannot undergo trabeculectomy or the patients who cannot have cyclodiode versus this.
Yes.
So the point was well taken. And I think he presented it in a very entertaining manner. So that's what we're looking forward to in OPL. That is very
I was not able to do the science in a 4-minute way. So just thought of conveying the traditional cyclo-destructive procedure versus the micropulse.
Yeah, very nice, very nice.
And then the learning curve in a comical way where the surgeon, I used to, when I started trab, sir used to be under tremendous stress.
Yeah.
Second, sir, when I take a flap, sometimes when there is an irregular flap, but when I learn micropulse.
That is also very good, yeah, that's good. And I think Seema's case was very well managed. And what I've seen is like the question is after 27 years, you have a spontaneous detachment. The endothelium is still good and it has gone back and started doing its function. Endothelial pump is fantastic. And that's very encouraging because that's what we should try first. Instead of jumping on to doing DMEC or DSEC and things like this, something as simple as that, very beautifully done, Seema, hats off. The other two, I think others can comment on.
Was there any history of trauma, Seema, in that?
Precisely, ma'am and sir. The whole reason what gave me confidence to do the decimatopexy in the first place was over 27 years, this patient meticulously followed with us at our, and not even a single episode of rejection. That gave me the courage to decide that definitely this endothelium would have potential, that it starts functioning back in its normal way. The only thing was it was 2 months after detachment when it came to me, and that is why I decided to use venting in supradecimatic, something we use the brave slash in double dark, but I kind of used it in this technique and it really worked well for me. Thank you.
No, there is no history of trauma.
No history of trauma, no history of recent suture removal, no vascularization of graft, nothing.
Nothing. Okay. By the way, headgear is also very good. Anyway.
Thank you, sir.
Chitra's comments.
Yeah, I just wanted to reiterate on what Dr. Murli said, that as far as trying it on a refractive glaucoma, it's any procedure which gives relief is acceptable, but I would definitely don't want the message across that it could be thought for a primary procedure unless we have a lot of clinical trials and there's some more evaluation which is done. And of course, Seema's case was just so amazing. An excellent video, Seema. I wish you can show it in many more podiums, and that clinical judgment and doing the right things and the venting incision was damn good. Actually, I'm waiting for this to get over to tell Shreyas how beautifully you did it. And the guys were just so amazing as usual. And although we do not understand too much of it, but I could clearly make out that the steps were so wonderfully done. Hip hip hooray to the Madurai team.
Very good. And Madhavan, you would like to have any comments on that? On all the players? Before we go on to the
quite entertaining. Quite entertaining. And Sriram finished it with a group photo with Dr. Mohan in the middle. A way to influence judge, I believe.
No, I'm not the judge. I'm not the judge. Yes, anyway, no problem. Thank you, Madhavan. And before we go on to Pramod and Manoj on the retina cases, I want to ask Kaushal that the patient had a fairly clear lens. You could have just done a lensectomy. Why did you extend the incision and brought it out?
Yeah, actually, I didn't anticipate it was more than 8 clock hours of GRT, and the retina was just lying. It was just lying on the retina, the nucleus. So when I went in, it was slightly anterior, and just it fell down. And then I thought to enlarge the incision, make it 20 gauge using a frag there, or even a cutter takes a lot of time there. So I thought it was very well. It's a soft nucleus only. Why can it bring it on and just deliver by a small limbal section? It was almost around 3 mm, because then managing the nucleus in lying over the big GRT is again it become a big issue. I wanted the GRT surgery to be complete. I want the nucleus out. That's why I did.
Okay, over to Pramod and Manoj. What exactly you would have done differently?
Basically, before coming to that case, because what Dr. Chitra said and Dr. Murli said, I agree, because since this micropulse laser is there since almost 91, 92, it's not a new technology. Why it still not become popular is because you need a lot of assessment, lot of judgment when you use them as the procedure, because no obvious reactions you see, and that's why good amount of experience is necessary. So totally agree with them. It cannot be just convey the message that anybody can use it and everything will be fine. Need a lot of experience dealing with that. Coming back to Dr. Koshal's case is exactly what Dr. Mohan Rajan asked. That is what my question was. Yes. So yes, GRT was there, but lens was absolutely soft. You said 20-year-old guy,
yeah,
soft lens. There's hardly any nucleus crisis. Any gauge 20, 25, 20 is 3. Even 27, I would have said very easy to chew this lens off. I would not have made a section. Absolutely. So that was something different, I would have said. And he mentioned also anterior flap, he has cauterized. That's what he used the word. Why not to remove entire flap? Has he removed the flap after that, or just cauterized and left it? As if leaving that, that's not a good idea. Long term, it can have its consequences. That was my reservation for that part. Manoj, you would like to add something?
Yeah, Pramod, as you rightly, the anterior flap is always better to be removed in GRTs.
Yeah, anterior flap to be removed, but that always depends on case to case. And we have actually the master of GRT surgery, Dr. Pramod Bende sir, this comment already. So I will not like to add anything. And just a small comment that I feel the laser was little too extensive as well. I would not have done such an aggressive laser. It causes its own problem, especially in GRT eyes. Once the retina flattens down to minimum 2-3 rows of laser should be sufficient. That takes care of it. And Shriram sir's case, again, competition for MR sir's case of Murugamuthu, quite wetly managed. And the patient has got a good amount of anatomical and visual outcome after penetrating foreign body. That's quite encouraging to see. Thank you very much.
I would like to add one comment here. Really want to congratulate Sriram for this case. The reason is what is important here is inspect and have an external examination is so important here. Don't think foreign body is gone inside. So yes, examination before taking for a surgery in OPD, on table again look under high magnification, check for a conjunctiva, try to look under the conjunctiva, and probably that's what he picked up. Something is there, bulging there, some pigmentation, some elevation, and that gives a likely clue that probably some part of foreign body is projecting, which made his job extremely easy. I think that is what is most important. Good examination.
And we are always
very, very important.
Tempted to go in.
Guidance, sir. All your guidance.
Yeah. It's a golden message by Pramod and Manoj on this particular thing. Examine and probably do a good slit lamp examination intraoperatively under the microscope. Examine all quadrants very carefully, and then before you venture to go inside. And
sir, even your comments, I have.
On behalf of our team,
I like to add you.
Yes.
Even I like to add your comments, which you tell everyone. Torchlight examination is the first thing should be there in the OPD.
Absolutely. Yes. My dad used to hit me with the torch if I don't see. If I see the patient straight away on the slit lamp, and that's what I have learned how to do it. And I always tell my postgraduates the same thing. Before we go on to questions from the audience, Nivian.
One last point from me, sir.
Yes, sir.
All the props which you are using, the mask with the monster label and our headgear, it is actually made from face shields. So we've all used our PPEs to make all these props.
Amazing. Hats off to you, Sriram. Anyway, Nivian, any questions from the audience?
No, sir. There are no questions for this team.
No,
One time also for the judges.
Removed from the eye, sir.
No questions in the audience. Any of the panelists want to make any other remarks before we go on to the next team? Before that, any other panelists want to make any remarks?
No more comments.
Okay. Before I introduce the next team, which is the Chennai Kings, I would like to ask, because Dr. Siddharthan came in a little late. I see him on the screen. Siddharth, are you able to hear me? Siddharth.
Sir, you have to unmute.
Yeah. I can hear you. Thank you.
Siddharth, welcome, Siddharth. Good morning, Siddharth.
Sorry.
Salem or airport, Siddharth?
Yeah, I have to come down. So now I'm okay. I'm in Salem now.
You are in a different level. You have to come down to our level. Please come down.
I'm here in Salem now.
I just wanted you, as a judge, I wanted you to say a few words because we are not there at the beginning.
Okay. Now, first of all, now to have this TNPL through Zoom is really fantastic. I mean, to pull it off is excellent initiative, and hats off to you guys. And I'm enjoying the show.
Thank you very much, Siddharth. And we go on to the next team, the Chennai Kings. Okay, we have none other than Dr. Srinivasan Rao. Dr. Srinivasan Rao is a top cataract surgeon, and he takes care of Agarwal Hospital, Tambaram, and he is the right hand for Amar Agarwal. And Srinivasan Rao is a very, very dynamic, and he is always a part of my team, Chennai Capsules, which has been the winner so many times. And Dr. Karthik Srinivasan is a dynamic vitreoretinal surgeon from Aravind Eye Hospital, Chennai, and he is also going to demonstrate some very, very interesting VR cases as well. Dr. Anand Parthsarthi, who is a cornea and cataract surgeon, he's got his own hospital in Chennai, and he's also a very prolific vitreoretinal surgeon. He's trained in SNEC Singapore, and he's a very top guy here. And Dr. Parivardhini, who is a glaucoma consultant from my alma mater, Shankar Nethralaya, and she's going to show some very interesting glaucoma cases as well. Over to Chennai's Kings for the next 16 minutes.
Good morning, sir, and thanks everybody for organizers and respected judges. And I'll share my video. First, I'm going to start on cataract. So before going to cataract, I'll show a modern day surgery. And in this, how the couching is done. In this, I'll start with this previous day. Complete inspection is done by our Nirmal Frederick sir for the OT, and the license of NABH was given. To maintain the complete sterilization, you have to cover it. Otherwise, the coronavirus can attack the eye. Keep it in the pocket and take it to the OT. Now, puncture 3 mm away from the limbus for the couching. Previously, it was done. And separate all the zonules, and the nucleus falls in. It is a very safe procedure. Previously, they used to do from long time. In India, they have done this. And the upper lid should be held by the thumb of the hand. In case the upper lid slips, you can use the wall, because you have wiped the wall with a Domex liquid, which is commonly used in the household, and so that the sterilization is maintained. And now you can see how the couching is done. And the nucleus falls. Previously, the only concept is the light entering the eye, and the vision concept was not that great. It was long back they were following this. While there are a lot of small side effects like retinal tears, bleedings, all this can happen while doing this procedure. Not a major side effects. This can happen when we're doing this procedure. And judges, we have also packed our PPE for you people, mask and other things. Now I'm going to show a case of traumatic cataract with the traumatic mydriasis. It's a complicated cataract, and the lens is subluxated. Now you're using an air pump, and you're bringing the nucleus out to the anterior chamber and doing a vitrectomy under the iris. And we are going to do a blue diode, that is by a scaffold technique. The 3-piece foldable lens is injected under the nucleus. And this procedure has been shown variously by Professor Amar Agarwal and Mohan Rajan sir in various conferences. You catch hold of the lead haptic through the blue diode forceps and bring it out of the wound which you have created and externalize. Now you ask your OT staff to hold this haptic and introduce the trailing haptic and exchange by handhold technique. The routine fluid IOL is done. Here, the only modification we are doing this procedure because of the cataract is there above the lens, so that the haptic should be tucked in before continuing the procedure, so that the scaffold, the IOL, acts as a scaffold and prevents from the cataract nucleus going down. Now, once the Shariat sprockets and everything is created, the haptic is stuck in, and now you can go ahead and handle with the cataract. The cataract is of a very normal traumatic soft cataract, not much viscose is required or energy is required for emulsifying the cataract. It's just a general aspiration. Most of the time it comes with the very minimal energy. You can note the anterior chamber is maintained by the AFM technique, and the blue IOL scaffold technique helps us from the cataract going down. The air pump is on always, so that the deep anterior chamber is maintained. You have to be very slow in this because it's not like the routine where we have a PC where the lens can dislodge and other things. And you can do a thorough anterior vitrectomy. To complete the vitrectomy, you can introduce the triamcinolone, intraocular triamcinolone, and see any vitreous strands or remnants are there. Once this is done, we have to think of the handling the next step of the pupil, because the pupil is also here because of the traumatic mydriasis. We have to bring it back with the help of the forceps. We are doing the single pass 4-throw pupiloplasty by 10-0 Prolene suture is used, and by railroad technique, bring the needle out and take the 4 loops, not the 3 knots which are tied for our life or our marriage. Here 4 loops is done, and the pupil is constructed. Here you can see the endo illuminator is being used, so that for better visualization. Once you can do any number of single SFT procedure, either this side or that side, so that you get a round proper pupil, so the patient doesn't have an excessive glare. The whole concept of doing the procedures, this can be done clearly done by an anti-segment surgeon. In case sometimes we have, when you are starting the initial procedure, there are other problems also where we are referred to the VR surgeons also. In case you can't do that, anti-segment surgeons can do this procedure very clearly. Once all these things done, we are closing the flap after the loops and all taken, a round pupil is obtained. Once this is done, the glue is done and the trocar anterior membrane is removed, and introduce an air bubble. See to that all the wounds are closed. Thanks a lot for giving me this opportunity.
Excellent. Karthik, go ahead.
I'm just, good evening, good morning, sir. I'm just sharing my video.
Presented with complaints of loss of vision in the left eye for the last 3 weeks with BCVA of left eye as less than 20/1000. Fundus examination in the left eye shows preretinal hemorrhage with subhyaloid hemorrhage with suspected macroaneurysm in the supratemporal quadrant of the macula. Left eye OCT through the fovea shows
Karthik, I would suggest, Karthik,
Yes, sir.
I would suggest you reduce the audio on the video.
Okay, and I'll present.
To talk will be better.
Okay, so now you can
start from the beginning. Start from the first.
Okay. So this is a case where you have a preretinal hemorrhage over the macula, and the patient is a 52-year-old female who presented with the 2/60 vision with a duration of 6 weeks. Now you can see that there's a preretinal hemorrhage which has some dehemoglobininized blood, and on OCT through the fovea, you can see that there is subhyaloid hemorrhage with aftershadowing with an intact ILM. The ILM over the subhyaloid hemorrhage is intact, and the OCT through the RAM shows elevated layers, producing a shadowing effect of the deeper retinal layers. The ILM is intact, and you can see it over the OCT that you can see the blood inside the intact ILM. Then the patient was advised to undergo YAG hyalotomy for draining the subhyaloid hemorrhage over the fovea, because the blood over the fovea will cause macular toxicity. And while we planned this, we thought that we'll also introduce an intravitreal bevacizumab, which will be planned for the same day. So while the drainage YAG hyalotomy was performed, and after 3 laser spots were given on the inferior most dependent part of the hyaloid hemorrhage, post the drainage, there was some pulsation that was present that you can see on the video. And on further evaluation, it was noted to pulse on a regular rhythm with the heart rate. as compared to the pulsations on the disc, which was seen by observing both the RAM and the optic disc in one single viewing slit. This video was taken with the use of a main set lens, which we use for PRP laser, and we could see that it was pulsing along with the optic disc rhythm. So there was no choroidal detachment or any altered pulsation seen over the vortex veins, and the cause of pulsation of the RAM seen post-YAG hyalotomy is poorly understood. We were hypothesizing that the retinal macroaneurysm has a thin vessel wall and accompanied by decreased elasticity. So the post decompression of the elevated hydrostatic pressure, there was the taut ILM which was ruptured, so there was a micropulsation. During the second day, there was no pulsation seen, and there was an increase in the subretinal blood. And on OCT, when you see, there is that vitreous hemorrhage that was dispersed due to the YAG iridotomy, and there was a pulsatile, there was a polypoidally elevated area that was seen over the RAM. And then we decided that this RAM, we will wait for one day because it was not coming onto the fovea. We thought that we'll wait for 1 or 2 days. Once the patient came back to us after 2 to 3 days, there was an increase in the subretinal bleed. Now the fovea was involved. The main reason we did this YAG iridotomy was to remove the blood from the fovea. Now we had it again. Then it showed an increased polypoidal lesion on the OCT and with subretinal fluid. So when we saw subretinal fluid with an increase in the polypoidal lesion, we thought that we'll go ahead with an intravitreal bevacizumab injection to make sure that the subretinal fluid and the hemorrhage will go away. So we made sure that all precautions were taken because this was already a laser eye. And then 3 weeks post intravitreal bevacizumab, you can see that the lesion is resolved on its own because of the intravitreal bevacizumab. And there was no evidence of any polypoidal lesion seen on the OCT. There were minimal changes that were seen because of some remnant dehemoglobinized blood that was present subretinally with cystic changes. And this time the patient presented with 6/12 vision. Once this was done, we waited for another 3 more weeks to reassess the patient again. And after about 6 weeks post intravitreal bevacizumab, we had a visual acuity of 6/9. And there was minimal cystic changes that were present over the fovea with a taut, mildly taut ILM that was present. And this was the first time that we have seen pulsatile retinal arterial macroaneurysm post YAG iridotomy. And to our knowledge that we have not seen any previous records of the same. Thank you.
Well done. Over to Anand Parsadi.
Sir, I'll stop sharing the screen.
Yeah.
I'm sharing my video. I'm having a bit of an issue. 1 second.
7 minutes remaining, sir. Can we go to Parivardhani then?
Parivardhani and then come back to Anand.
Yeah.
Can you just sort out Anand? Meanwhile, Manjula.
Yeah, shall I start?
Yeah, sir. Parivardhani can start.
Yeah.
And
Thank you, sir.
Manjula to sort out Anand Parsadi, please.
So, yeah. Good morning and thanks for the opportunity. I am presenting a case of a 49-year-old male who had eye syndrome with glaucoma. He was on all topical AGMs. Is it not shared?
No, you have to share the screen, ma'am.
I thought I had shared. Sorry.
Share the screen and then start from the beginning. Yeah. Now we are able to see.
Yeah, thank you.
Good.
Yeah, thanks for the opportunity, sir. And I'm presenting a case of a 49-year-old male who had eye syndrome with glaucoma in the left eye. He was on all topical AGMs along with astazolamide. The right eye was normal. The left eye showed corneal decompensation with very high peripheral anterior synechiae seen 360 degrees. The lens was clear. The central and the peripheral anterior chamber depth both were shallow. The vision was 680. The disc was hazily seen, looked okay. And on withdrawing the acetazolamide, the intraocular pressure was going up till 36 millimeters of mercury. So we had a young patient with iridocorneal endothelial syndrome with uncontrolled pressures, decompensating cornea, and a healthy disc who had very high peripheral anterior synechiae. Since we wanted to plan for a stage procedure, we thought of controlling the intraocular pressure first and then plan the corneal intervention. So how to manage this case? And what are the challenges in this patient? So trabeculectomy was definitely not an option because of the presence of very high peripheral anterior synechiae. And since the patient already had a very good vision with a healthy disc, we didn't consider cyclodestructive procedure. Ahmed glaucoma valve was an option, but the tube cannot be introduced into the anterior chamber because the anterior chamber was shallow. So the advantage in this case is the peripheral iris is pulled up and the sulcus is widened. So we thought of putting the tube in the sulcus in a phakic eye with slight modifications. Let's see what it is.
சூடமாடு போய் அந்த பையன் பேசணும்னு சொல்லணும்னு சொல்லிட்டு
Give the audio, ma.
பெரிய பொண்ணு ஃபோன் பண்ணா பேசுறதுக்கு பேசிட்டீங்களான்னு கேட்டாங்க. கிருஷ்ணாஜி அவன் பேரு. கிருஷ்ணாஜி ஐயா ஃபோன் பண்ணாங்க.
Hello, please, Sujata, please unmute. Please mute, I'm sorry. Parivardhini, can you just... We're not
yes, sir.
you.
Not able to hear me?
Yes. Now you are very able to hear you.
Okay.
Please describe the video.
Sorry, sir.
Please talk about the video.
Yeah, there is a voiceover, sir. You're not able to hear?
No, you're not able to hear. That's the reason.
There is full volume.
Don't worry about the voiceover. You just talk.
Okay.
Start the video from
from
the beginning.
Yeah. So the AGV surgery was. So the AGV surgery was usual steps only with the conjunctival opening, limbus base done at the superior temporal quadrant. So the plate was primed and it was anchored to the sclera, 8 millimeter from the limbus. The modification in this procedure was the creation of a superior surgical PI at 12 o'clock. I did it under viscoelastic cover with the use of a light pipe because the corneal condition was not allowing me to see the anterior chamber clearly. Then a 23 gauge needle was introduced into the sulcus 2 millimeters from the limbus. With the PI as a guide, I introduced the needle into the sulcus, avoiding the lens and keeping the needle parallel to the iris. Then the tube was inserted so that the tip would lie above the iris and not in the sulcus, so that it is not in touch with the lens. Then the usual procedure of VGV was done and completed. So the difficulties in this case was that the cornea was hazy, there was poor visualization, and under this visualization, the tube had to be introduced into the sulcus in a clear lens. So this was possible with the use of a light pipe. So post-operatively, the patient maintained 618 vision. The corneal clarity improved and his visual symptoms also improved. His intraocular pressure has maintained at 14 millimeters mercury under 1 AGM. So we can see the tube here in the sulcus. However, I had placed it in the sulcus, the tube tip also, but because the PI had widened, because the iris was thin, the tube tip is also gone into the sulcus. Thank you.
Very nice, Parivardhini. Go on to Anand Pasadi. Is he okay now? Vivian, can you just check? Vivian Ravishankar?
Anand?
Yeah.
Yeah, we have 4 minutes remaining. Can you share?
Yes. It's just, can you see my video?
No.
You have to do the screen sharing.
Screen sharing.
I did that. It's all.
Have to do.
Okay, can you see it now?
Yeah.
Yeah. Yes.
Yeah.
Just
Good. Go ahead.
All right, this is about thinking beyond the usual. So an ideal graft is a generous graft, tenon-free graft. So in recurrent pterygium, if the technique is not good, you'll get a recurrence. So I'm introducing something called a perfect technique, that is pterygium extended removal followed by extended conjunctival transplant. It's a modification where we do a pterygium excision, we do wide excision and combine it with mitomycin. Now this is a 82-year-old lady operated for a primary pterygium regrowth with recurrent attacks of redness and visited multiple eye hospitals. So if you can make out an extensive subconjunctival fibrosis, associated melt is the complicating factor. And when you do an OCT, she's got only about 200 plus microns at the thinnest point of the pterygium. So it's a recurrent pterygium excision with perfect technique. And what we are doing new is a tectonic tenon transplantation. So the excision here is important because you got extensive subconjunctival tissue. So it's a practical approach to a not so simple problem. We have already harvesting the tenons and keeping it separately, and this would be used later. Now, what is important here is to do a lot of excision of the subconjunctival tissue so that you're on the bare sclera. In recurrent pterygium, this is very, very adherent. So I'm using a combination of a number 15 blade. You can use a burr, which also is available. And once you do that, you also have to be aware, of course, that in recurrent pterygium, the pterygium can involve the muscle. So you have to be very, very gentle. And in this patient, we have to be very careful with the medial rectus. The pterygium donor graft is then harvested just like normal. But because it's a recurrent pterygium, the graft has already been taken once. And the tenons is almost well attached to the conjunctiva. So the donor graft takes a lot more of effort. Now here I'm doing an excision of the subconjunctival tissue all the way up to the limbus, up to the fornix, so that there is no recurrence chance. It's important that you do this and remove all these fibrosis, because if you leave this will be a worse recurrence than what you had the first time. And of course, you have to be careful. You have to make sure that you do not cut unnecessary tissue. In this patient, the muscle was critical. So we isolated it with a muscle hook and then gradually, bit by bit, removed all this extensive subconjunctival fibrosis, both superiorly and inferiorly. Sometimes you need to go up to the fornix till you see a bit of the orbital fat. So you have to be very, very careful. You can see the subconjunctival tissue stuck onto the sclera. This needs to be removed or else your graft will not stick. Once you have done that, you attach the graft. Now the conjunctival graft is attached. I've actually put a bit of the tenons and I'm doing an overlay suture. Now this is important. Once you put a drop of fibrin glue, you do an overlay suture, not a suture through the tenons, but an overlay so that it just presses down the tenons. And because this is fairly soft tissue, so if you do a standard suturing, you would definitely have a cheese wiring. And you do a cross, and I'll show you how this is done, like a figure of 8. And once you finish, you put the graft, you put fibrin glue, you've done the graft, you've done mitomycin C, you've used a conjunctival autograft, and this whole procedure is then actually complete. Remember that the important point is extensive resection, mitomycin, and then of course follow up. This is 2 months. You can see the suture. This is 4 months, and patient actually now is planning for a cataract surgery. Thank you.
Very nice, Anand. That's the end of the Chennai Super Kings. Chennai Kings has been seriously amazing presentations by all of them. They had a variety of cases. And then before we go on to the panelists, I want to ask Dr. Srinivasan Rao, who is the first speaker of the Chennai Kings, the opening batsman, whether for coaching you take COVID consent form also.
Yes, sir. We take COVID consent and give hydroxychloroquine as advised by our Trump Anna, sir.
Oh, very nice, very nice. And I will go on to the panelists. Let me start with Dr. Sujata. and on the couching technique, and also the glued IOL, the scaffold technique, what Srinivasan Rao, and also the you can even mention, give your comments about the glaucoma case as well. Sujata, please unmute yourself.
Okay, I would just start with Dr. Parvadini's case. It's an excellent case because these sort of eyes, with eye syndrome is very, very difficult to handle, and they have chronic glaucoma. Most of them end up with corneal transplant surgery, and they also fail because of this angle problems. And I think she has handled it very beautifully. I think the next stage, probably the patient might be in need of a corneal transplant.
Yes.
So I think but that's a very well done surgery, and the decision to put it in the sulcus is something very different and really well done, Dr. Parvadini. And coming to Anand's case, I'm not able to understand the reason for using a TNOA graft. Is it because you wanted to bridge the depression in front of it is taken? It's become thinned out. The cornea is thinned out.
Correct. Yes, because it was very correct. Because what is the recurrent pterygium is causing something like a Dellen effect, and it's causing progressive thinning. So it is a tectonic TNOA transplantation, Sujata. What you're saying is correct.
Yeah. Okay. Right. I mean, it's a difficult surgery also because you can see the amount of fibrovascular tissue overgrowth. They're extremely difficult to dissect, and the amount of bleeding and all that is quite difficult to control. And it has been done very well by Anand, and he's an excellent surgeon, as we all know. And I think I will refrain from commenting about Dr. Karthik Srinivasan's case. Just a few words about Srinivas Rao's case. It's a very well done mixed up video with showing lots of different procedures. I think probably the take home message in your case is the SFT, because that is what is Agarwal is all about, the SFT which they are publishing regularly. So well done, all four of you. Excellent team, and all the very best to you.
Thank you, madam.
Go on to, thanks a lot, Sujata. Go on to Chitra. You comment?
All excellent surgeries, and I'm not going to be too repetitive because Sujata seems to have covered most of the points. Doing a scaffold with a glued IOL approach, definitely there's a little more limitation in the visualization, and Srinivas has done a great job there, and that is very creditable. And of course, the glaucoma surgery was also good. We've also, we do sulcus placement of the tube often enough, but I could appreciate the idea of her doing a PI, and that too, it was a clear lens, and how she went about it in this situation, which is a very challenging case, was admirable. Retina surgery was also very good, extremely good. And of course, Sujata has said all the things for Anand's case, and that was also a very well done surgery. Kudos to all of you.
Thank you. Thank you. And any suggestions from Madhavan? Madhavan, then we go on to Murli Ariga on the glaucoma cases as well. Madhavan.
Siddharth also wants to talk.
No, Madhavan or Murli Ariga, can you come online?
Yeah, I'm here.
Yeah, Murli.
I think like the others mentioned, the IC syndromes are very tough to manage.
Your audio is going off, Murli.
Managed it very well. Am I clear?
Not very clear.
Am I back now?
Okay? Yeah, now? better. Please.
Yeah.
Go.
The IC syndromes are quite tough to manage, and I think she has done a great job. But we can expect further problems like cataract, corneal decompensation, and end up with corneal problems and transplants and so on. I only have one small point to suggest when you're doing this kind of IC and AGVs in phakic eyes, is that instead of going in from the superior part and doing iridectomy through the limbus and cornea, the Cyclo can be used, and you can use a vitreous cutter, go make a gentle small iridectomy at the place inserted, and that will make the iridectomy a little smaller. So that is one way of putting in the tube that way. And of course, you may, end up with, despite all that, you may end up with encysted blebs and raised intraocular pressures. You may have to manage that and even consider cyclophotocoagulation much later. But the cornea is also a problem here. But I think the Srinivasan's presentation on couching was excellent. I think he's probably reviving couching in Tamra.
That's a good one. Actually, Murli, what is your first line of treatment as far as ICE syndrome is concerned?
Well, first is, of course, the medical management in milder cases and probably not to intervene. But when it comes to surgery, I think trabeculectomy will not work. That is for sure. Invariably, trabeculectomy will fail, even if it is taken.
So you also suggest a tube?
Yes, primarily a tube is the best option for the patient. Instead of avoiding multiple surgeries and blood fibrosis and so on, a tube is the best option primarily itself.
Is there any role for G6 in this?
Yes. What I would probably do is first attempt, because a young patient with phakic eyes, I would probably attempt.
Your audio is breaking. Your audio is breaking.
The tube first, and the pressure remains uncontrolled. There's some complication and doesn't do.
Your audio is breaking.
So well.
Yeah. Nivian, can you ask?
The G6 is a good option, not as a primary procedure for seeing eyes with these kind of patients. I would probably prefer the tube first, then look at G6 as a second option.
Okay. Thank you very much. And
yeah, so
we go on
what
to
I was trying to say, G6 is a good option. Yeah, the G6 is a good option, but not as a primary procedure for these kind of eyes. I would still prefer the tube first, like what Parivardhini had done.
Okay.
What about other panelists for retina? You have not asked.
I'm going to that. We go on to Pramod and Manoj. Before I start the discussion on the retina cases, I want to ask Srinivasan Rao. See this glued IOL, okay, the scaffold.
Yes, sir.
You are putting the glue, the lens underneath the crystalline lens. Okay.
Yes, sir.
Am I right?
Yes, sir.
The problem is, see, it's a very good technique. Only thing is, I'm a little concerned about the vitreous there. So that's what I want an opinion from Pramod Bande and Manoj Khatri and also Karthik Srinivasan on this. Because I feel that we should primarily manage the vitreous first, the vitreous which is there in the pupillar area, and then put the lens underneath the lensing and then probably use it as a scaffold. I want opinion from Pramod and Manoj as well as on this, as well as on the retina case. Pramod?
Manoj can take first.
Yeah, Manoj can take first, yes.
Yes, sir, I totally agree with you. I will be wary of, causing undue traction on the vitreous and causing problems with the retina. Let's manage the lens first. And there are so many good techniques people are doing nowadays with glued IOL and even Yamane technique. So IOL, even at the primary sitting, we are not able to put it. We can do it at the secondary stage procedure, no problem at all. And another problem is corneal decompensation with this, nucleus so close to the corneal endothelium, and you're doing phaco in that area where the space is less. So that is another problem.
Yeah.
And so these are the two things. And also sometimes the phaco tip itself can, also cause the optic damage as well. So that is another thing which we have seen in post-operative period. And then we tend to think whether the patient would have gone for IOL exchange and stuff like that. So we'll take comments from PB sir on this case and then go to Karthik.
Yeah, PB.
I totally agree with Dr. Mohan Rajan and what Manoj said. 100% agree with that. I'll be very, very hesitant to go ahead with this procedure. Now, if I understand correctly, the only advantage of this technique is the surgeon does not want like a loose pieces of lens falling down in the vitreous cavity. If I understand correctly, that's the whole purpose of doing entire these gimmicks.
Absolutely.
Yeah, and with all this thing also, because there is no capsule here, even though you have an IOL there, cap around, there's every possibility loose pieces still can slip. Okay, so it's not a foolproof thing. But yes, I am worried about the compensation. I am worried about vitreous, and yes, matter of time, you will end up having some problem with a peripheral tear and patient coming by with ID. I won't do this technique. Let me put it very clear.
Yeah. Karthik, you have what about the retina case by Karthik? Pramod, I want your opinion on that.
Retina case, as far as Karthik case is concerned, I am little bit confused because sometimes he says like a polypoidal thing. Sometimes he said like a retinal artery macroaneurysm. But basically, clinically, what you look at, this is a retinal artery macroaneurysm because terminology is important when you are conveying message to audience, and particularly postgraduates are there. Correct diagnosis is very, very important. Yes, it's a case of retinal artery macroaneurysm. And I don't see any role as far as anti-VEGF is concerned. Why, with or without anti-VEGF, probably would have cleared him. That's what I feel. And this is the only condition you can have a pre-retinal hemorrhage, intraretinal hemorrhage, and subretinal hemorrhage, I would say. Okay, that is also goes with a because retinal macroaneurysm.
You would have done the laser as well?
Laser, this case, I mean, laser is one of the modalities, but we need to understand at what layer you have a heme, because he has shown the heme as far as OCT is concerned. If it's sub-ILM heme, probably it will not clear that easily compared to sub-hyaloid heme, basically pre-retinal heme. This heme already what he has shown, probably upper layer is liquefied, but we have a thick alter blood, which is settling at the base. I mean, he was lucky enough that liquid thing has drained out, but that plaque will remain as it is. So probably more than a month or two. Again, probably laser, you will be hesitant because may not help much, because the fluid will get absorbed eventually. That is not going to cause toxicity. And that heme part is already settled down. So probably I would have just observed.
Yeah, Karthik, you have anything to say?
Yes, sir. Pramod sir, that case we diagnosed as a retinal arterial macroaneurysm. Only thing was the polypoidal I mentioned was on the post-pulsatile event. Only after that did the polypoidal lesion come up. So the polypoidal lesion was the OCT finding. It was not the diagnosis part. And once that had happened, when the subretinal, we waited for 2 more days. And once the subretinal fluid started accumulating with more of subretinal bleed happening, only then did we think about having an intravitreal bevacizumab to be given.
Yeah. Manoj?
Yes, sir. Very nicely documented case, Karthik. I will, give full marks to you for that. And we know that the diagnosis was straightforward as a retinal artery macroaneurysm, and you showed beautifully the pulsations. And these cases are known to cause multi-layer hemorrhages, as pointed out by PB sir. The most difficult one to handle is the subretinal bleed, and I think the patient was very lucky that the subretinal bleed cleared up so well, and the patient regained such a wonderful visual acuity, which is little rare in these patients. The only thing I would have advised, or I would have done differently, is I would have waited instead of giving 1 or 2 days gap. I would have waited for a couple of days to couple of weeks for further intervention, repeat intervention. That's the only thing because we are always scared to do intervention in this patient at such a short interval. So that's the only point I would like to add on. Rest very well managed and beautiful visual acuity achieved at the end. Thank you.
Any other questions from the panel? Nivian, you want to say something?
No, we'll go on to the last team, sir. There are no more questions.
Okay, we are running short of time. Any questions from the audience? No.
No, so the youngest OPL team is still waiting.
Yes. Over to Dr. Ravishankar to introduce the Salem Stunners.
Thank you once again, sir. And just to remind the judges, 3 teams are over. I think you are getting the points done over there. To remind you, it's 10 points per player and 40 points per team. So judges, and you are confused or you're not confused, I do not know. But still, that's the 4th team for you, the Salem Stunners. We have Dr. Jayanthan from Erode, a wonderful cornea and refractive surgeon, and also a cataract phacoemulsification surgeon. And he's been too good recently in most of the talks in a couple of recent webinars also. Thank you, Jayanthan, for participating. The next participant in the Salem Stunners is Madana Gopalan, who's a prolific, young, dynamic vitreoretinal surgeon. Thanks, Madana. And next in the list is Dr. Sapna Sinha, who's a corneal surgeon from Arvind. Thank you, Sapna Sinha, for accepting to be here. And last but not the least, in the Salem Stunners, we have Shruti Vaishali Ramesh from the Mahatma Trichy family, who will be presenting a cataract case. On to Salem Stunners. Jayantan. Jayantan, who's starting?
Jayantan is starting.
Audio, please. Jayantan, audio. Please speak.
Can you hear me, sir?
Yes, sir.
Yeah, thank you, sir. This is a video of a 40-year-old gentleman who's a known diabetic who came with the complaints of defective vision for a couple of weeks. He has a history of getting an injection in his eye a few weeks back, and you can expect what could be seen on the posterior capsule. So it's already a posterior capsular tear which is lying there, and I'm going to do a quick investigation for this patient. So the key here is to have a rightward rexus, because as you want to implant an IOL, so the main thing is to have a very good rexus here. Because if something goes wrong, you need a good sulcus where you can implant the IOL and then buttonhole the IOL back into the capsular bag. So a nice rexus was completed and the hydro delineation was done. So always make sure there is no hydro dissection. Never attempt to do a forcible hydro. Make it very gentle. Slowly tap out the fluid and then start doing it. So use a low power, high vacuum. Just use a vacuum assisted aspiration of the nucleus. And so the nucleus is going to be soft. Make your emulsification much smoother. The main idea is here, the chamber should not collapse. So keep your flow rate optimum so that the chamber is not collapsing at any point of time. Eat bits and pieces of the nucleus, slightly aspirate, keeping the probe at the center. And once the emulsification is done, always make sure you inject a high molecular viscoelastic and then take the probe out so that the PCR doesn't extend. My preferred technique of doing a bimanual IA is to do with the bimanual incision, because you can control both the irrigation and the aspiration separately. The aspiration can be kept at a moderate rate and the irrigation kept constantly flowing into the anterior chamber away from the posterior capsular rupture. And I'm not switching over the handpiece here because at the time of switching over the handpiece also there could be a change in the fluctuation in the anterior chamber. So I just want to avoid that. And so handpiece is kept in the same mode, and you can now clearly see the posterior capsular rent that is there. So once you've done all these things, you'll always have a gush of adrenaline, which will tell you there are small bits and pieces of epithelium lying around there. So I started doing the PC polishing, and to my luck, all this also came out very well. So you can see here that the rexus is perfect, and the bag is completely polished off now. So I'm going to implant an IOL. Initially, I thought I'll put a 3-piece IOL, but since everything is fine and the PC is not extending, I thought I'll put a single-piece acrylic hydrophobic IOL inside the capsular bag. And that's a lens that got into the capsular bag. And once the lens is in place, you can see that the posterior capsular rent that has already occurred actually comes in the view of the visual axis. So gradually this patient can actually develop a fibrosis around the margin, and then it will disturb the visual axis. And so I thought I'll just convert it into a posterior capsular rexus. So since it is a fibrous one, it was easy to grab, and then I completed the capsular rexus, making sure the visual axis is very clear. When I was discussing about the lens to the patient, the one thing which he was very adamant is he wanted a distortion-free clear vision. So I just want to make sure the visual axis is perfectly clear till the end of the procedure. So the viscoelastic was aspirated, and as you could see here, I could see the shards shining in my eyes. But the one thing that hit my mind is that the patient wanted a distortion-free vision, and you can see there are shreds of epithelial cells which was hanging around in the anterior vitreous. So everything was fine in the anterior chamber, but there was a small glitch in the anterior vitreous. So evlovo pannitom idha panna matama. So then hydrated the wound. I just don't want to do any of the procedures from the anterior chamber, because anything more in the anterior chamber can attract the vitreous to the wound. So I just hydrated the wound. Now did a pars plana trocar entry. So using the self-sealing wound, I just went ahead, did little bit of shallow anterior vitrectomy so that even the small bits and pieces of the epithelial cells which has gone into the anterior vitreous got cleared off, so that the patient can have a distortion-free, clear vision post-operatively. And that's it. At the end of the procedure was the clear cornea and a centered IOL and a stable vision. Thank you.
Very nice. Next player.
Very good morning from Salem. Big thanks to TNOA and all the organizers for putting this together. I will be talking about how to convert threats into opportunities. Right now, in the middle of a pandemic, threats and opportunities abound. The human mind, when presented with difficult situations, has the uncanny ability to come up with brilliant innovations. Never let a good crisis go waste, as Winston Churchill once mentioned. So institutes like Arvind, S. and Shankara have been leading the way as far as these innovations are concerned. On our part, to make things easier for our colleagues, we conducted a large survey with more than 550 participants. The results will be published in the next edition of IJO. So converting uncertainties into opportunities, I'll be dealing about two instances, one in the anterior segment and one in the posterior segment. In the anterior segment, all of us have used a forceps on a three-piece IOL to convert it into an SF IOL. There are always difficulties. The Prolian haptic will break, it will flip, the IOL fall into the vitreous. So there are always a lot of problems. To counter these problems, thanks to Dr. Prabhu and colleagues from Arvind Eye Care System, the XNet technique was introduced. I'm sure all of us are familiar with the XNet technique. It's gained in popularity over the last few years. So using a simple 26 gauge needle, we are able to exteriorize the Prolian haptic. Now, taking things forward, we have changed the design of the IOL itself, and we have introduced the CM T-Flex IOL. Now, this is a single-piece foldable acrylic IOL with T-shaped haptics. This is a very simple IOL, very simple technique. It completely eliminates extraocular haptic manipulation. It includes just a pull and a release technique. Absolutely nothing further is required as far as handling the IOL is concerned. Here you can see we make partial thickness scleral flaps 180-degree apart. Cortical remnants are removed by pars plana vitrectomy. Then I made 23 gauge sclerotomies at 3 and 9 o'clock meridian, and SCS wound is opened. Now the foldable IOL is being injected into the eye, and a forceps grasps the T-shaped haptic at its hub. It's firmly grasped and gently pulled out of the eye to bring it out of the lateral sclerotomy. The trailing haptic rests on the iris. Now, using the handshake technique, the trailing haptic is also gently exteriorized. As you can see, one forceps transfers the haptic to the other. Once the haptic comes out, the IOL is in position, and it is as simple as that. You can see that the haptic firmly anchors to the sclera, and your surgery is done. So that was about converting a threat into an opportunity in the anterior segment. Moving on to the posterior segment. Any VR surgeon will tell you that using PFCL has a share of difficulties. Once the retina is stabilized, you have a lot of air bubbles forming at the fluid PFCL interface, and these air bubbles interfere with visualization. Secondly, you also have fluid currents running under the PFCL, and this can lift the retina either gently or in a massive way and can spoil your entire surgery. To overcome these difficulties, we came up with what is known as the sandwich technique of oil and PFCL. So once PFCL is injected and the retina is stabilized posteriorly, we inject silicone oil over the PFCL so that silicone oil occupies the anterior space. And now the eye is a firm closed cavity with oil in front and PFCL behind. You can see the oil PFCL interface there. In this situation, the globe can be rotated in any direction. You can do laser comfortably. There are no air bubbles. The retina doesn't flip. There are no fluid currents. After you have comfortably finished the laser, you can go ahead and fill in the remaining silicone oil, remove the remaining PFCL from the posterior part. So this technique was published last year in JOVR. So to conclude, now as always, threats and uncertainties will pop up once in a while, and it is up to us to use them as stepping stones or opportunities, innovate and surge ahead. Thank you all. Thank you all for patient audience.
Very good. Next player, please. Sapna.
Yes, sir. Sorry. Hello and good afternoon, everyone. I'm Dr. Sapna, glaucoma consultant at Arvind Salem, and I would be presenting a video on Journey Through the Tube. So sit back and relax and enjoy this tube experience. This is a surgical video of a tube shunt surgery in an eye with aniridia and advanced glaucoma. Now, glaucoma is associated with at least 50% of these eyes, and until we realize it, it's already too late and quite advanced during presentations. Aqua shunts have shown to be effective for glaucoma associated with aniridia with a success rate of about 88% at 1 year follow-up. So here we start off by placing the wings of the plate under the superior and lateral rectus muscles. And then the plate in the tube is well secured on the sclera with the help of partial thickness spikes. Now, this is Oralab aqueous drainage implant, and this being a non-valved implant needs tube ligation so that we prevent immediate tube filtration. So tube ligation is achieved by using two 6/0 vitral sutures. We have to ensure that the sutures are nice and tight, and you need to cross-verify that by trying to push the BSS through the tube. And as you see here, we're not able to push the BSS, and you can see the movement of the air bubble. Now, tube trimming, we need to trim the tube about 2 millimeters from the limbus, stretch the tube over the cornea, and make a nice sharp cut with a good anterior bevel. Now, choosing the spot where we need to start making the tunnel, it's important that we go 4 millimeters behind the limbus because we're aiming for a long scleral tunnel, and about 2 millimeters medial to the tube. So after we found our spot, we make a partial thickness scleral incision, and then we use a 23 gauge needle to make the scleral track. So it's important that, we kind of try to change the wriggling movement of the needle as we're approaching the anterior chamber, and then there is a direct dip in the anterior chamber. Now, the major challenge in these eyes is like this does not have an iris. A very gross visual appearance of iris can help us a lot in assessing and gauging the depth of the anterior chamber. So in eyes with complete absence of iris tissue, that's the major challenge to judge as to where you need to make your tube insertion. And slowly and steadily, as you see, the tube is snugly fitting inside the scleral tract, and we need to keep an eye on the tip as it's going inside the anterior chamber, because this is a phakic eye, and we have to avoid damage to the anterior lens capsule. So small modification in this, as opposed to other cases where I usually use a full thickness corneal patch graft, a partial thickness corneal patch graft fashion like this would be very helpful, because we want to avoid the bump near the limbus, because these eyes are also predisposed to limbal stem cell deficiency. So the partial thickness patch graft is very well placed to avoid Dellin and foreign body sensations. And then at the end of the surgery, you see that there is absolutely no iris stump, clear lens, and the tube, which is very well placed in the anterior chamber. So a very important point before I conclude is like inadvertent damage to the anterior lens capsule and formation of cataract is kind of common, especially in glaucoma surgeries following trabs and tubes. So these are usually seen in eyes with shallow anterior chambers, and you have a cover of iris when you're trying to place the tube inside. So analytic eyes, it's even more challenging because the absence of iris makes it difficult for us to judge the tube position in the anterior chamber. Hence, it's important for us to assess and do a stepwise approach to implant the tube in the AC. Thank you.
Volume is not there.
Shruti, you have to talk.
Shruti, please talk. Please give some audio. Start from the beginning. Shruti?
Yes, sir. Yes, sir. I'll start, sir. Yes, sir.
From the beginning.
Gone are the days of test series with no results. I am a T20 girl and I plan on clearing the path. So everyone, get ready and get your gears on, because it's going to be one wild ride. Fail once, we'll try again and fail better, because therein lies the secret of success. Here I had a case which had a PCR converted to a PCC, and I'm placing a 3-piece lens. But to my surprise, the things are far from over, and it leaves people on edge. The trick here would be to put enough visco to prevent any drop of the fragments. Ideally, you're supposed to make 2 halves and remove the fragments, but me being a novice made 3 and went a little overboard. But then again, I placed the second lens. And to my surprise, it wasn't easy either. I'm really hoping my spectators don't faint by the situation I'm in. But now my experience with cutting lenses has improved, well, because of the first one. And so I make a perfect cut along the middle and remove the remaining pieces. Finally, luck is by my side, and voila, the 3-piece lens is safely placed within the bag without disturbing the PCC. Without zero, we don't have maths, which is the basis of everything. Neo. With proper phaco-dynamics, you can do a zero-energy phaco, which is going to be a sweet deal on the corneal endothelium as well as the macula. And I love playing with the phaco parameters to make the perfect combo for a perfect surgery. The trick here being the reverse linear mode with the vacuum to avoid the post-occlusion surge, which we most fear.
It's not impossible.
Invariably, cataract surgeons have a love-hate relationship with PCRs, but it made us drop a lot of things. We all prayed for Nasamani. I think it's time we started praying for the training surgeon. So I thought, instead of referring these cases to my opponents and letting them earn more money, why not do it on my own? But I needed to train for my aphakia management. Iris claw, though simple, is a very useful technique to have at hand. Once my teammate digs out whatever fell in, I'll comfortably place an iris claw and become their savior. Same way I became the savior of Mahatma. And make sure you're checking out the correct dimple. Never underestimate the power of small packages like me. The 20s are definitely taking over. I mean, why not 20 intraoperative pressure? If you set your mind at it, anything and everything is possible. Even with low intraoperative pressure, success is a given if we adhere to the proper technique. Always start stepping down on your phaco parameters as you start approaching the last fragment, because we do need to protect the PC.
Thank you, sir.
Beautiful. Very nice, Shruti. And really kudos to Salem Stunners for really a stunning show. And that we come to the end of this OPL. But before that, we'll just ask the panelists. Let's ask the first question to Jayanthan, the first presenter of Salem. What I would have done differently, I want the panelists' opinion also. In your case, Jayanthan. Jayanthan, you're online there?
Yes, sir. Yes, sir.
Yeah. Is that definitely I would have done a femto because I have got access to femto when I have suspected PCR preoperatively, number one. Number two is I wouldn't have done any hydro procedure at all. Okay. Number two, that is number two. Number three is I would have done a posterior capsulorhexis before I implanted the lens. And number four is I would have put a lens. When I put a lens, I don't dial the lens. I just tuck the lens trailing haptic into the bag because I don't want that rhexis to or the posterior capsular tear to extend. And I didn't see any point in for you to go past planar route to remove that vitreous which is there, because you already removed the vitreous which is there in the anterior chamber quite efficiently. Some pigments may be there in the anterior vitreous. You can leave it like that. That may become all right with steroids. But I want the opinion of Sujata, Chitra, and all the panelists on this particular case and also the other cases as well. Over to Sujata.
I think I agree with you. I think all the points you pointed out were well said, and that's exactly what we were also thinking about. The other thing is, like, when you have converted into a PC, you could have done a capture. The lens could have been captured. so that it would remain more stable. That is one thing that we can do when you're dealing with a PCR. Particularly now, that should be the standard protocol. That's as far as Dr. Jayanthan is concerned. And the other team members, Madan Gopal, Sapna, I think Sapna did an excellent job. And Shruti has got a mixture of cases. It also went off very well. And I have no other comments.
Chitra?
Yeah, going on to Jayanthan, I do agree with much of what Dr. Mohan said. But let's also understand that Jayanthan showed the surgery so well. He showed that he could do well without a femto. Femto is not the only way to go, but yes, makes things easier. But he told us about the anterior chamber not shallowing and the attention he gave so that that doesn't push the vitreous into the anterior chamber. And every step he did was excellent. The only thing is without doing a PCC, when you inject the IOL, though that PCR was small, sometimes by the time you have injected the IOL, especially if you try rotating it, you should have, if you tuck it in, you are still safer. Sometimes the PCR can get bigger and you cannot convert it into a PCC. So that could become a challenge, and I would never have gone into the vitreous after that, whatever opacity you went after. But having said it all, for a young guy, you did wonderfully well. For even a person of our age, we couldn't have done it so well. So hats off to you. And again, Sapna, you were just very good, Sapna. Admirable, a beautiful teaching video. And hats off to you. And even your delivery was so good. And Madan Gopal, that was also amazing, the way you showed two different techniques. And each of it told us that this younger generation is there to just push me, Mohan Rajan, and some of our age groups into the area of being panelists and judges. And, you know, I realized that I was getting older now. That was wonderful. And Shruti, you were amazing for such a young girl, your perception of different techniques and the way you showed. Hats off to all of you.
Yeah.
Thank you.
Beautiful. I think I fully agree with Chitra. Murli, I want your comments on this, Murli.
Yeah, I think wonderful presentations, and I'm really amazed at the quality and the way these talks were delivered. And I think we have seen the array of different types of scleral fixated lenses. We've seen iris claw, and also we are seeing the T-flex as well as the other lenses also. I think really wonderful options for aphakia. And with regards to the glaucoma presentation, she has presented it so well. My only query to her is, with the RD implantation, we do have a possibility of a sudden drop in intraocular pressure. That's why the sutures are being applied. And also the intraocular pressure can remain high for some time in aniridia and other cases where the RD valve is implanted. So I think a venting slit in these kind of situations where you can manage the IOP in the immediate post-operative period when the IOP is very high, a venting slit is an option. And I think the cornea coverage of the tube is also a good option. So I think that you have to keep in mind. Aniridia is basically very difficult to deal with, and the glaucomas are quite bad, and cataracts are quite possible. I think the venting slit is an option.
Yes, sir. Thank you, sir. Yes.
Thank you, Murli. And I think Jayanthan, you did a very good job, and you managed the case very well. It's really a fantastic case. Only thing is, when you have a PCR, when you know there's a PCR, always keep injecting viscoat into the anterior chamber during your entire procedure, because the viscoat forms a nice, beautiful scaffold, and make sure that you lower your parameters and all these factors. I think he did a very nice job as well. How many of you in the panel would have, before we go on to the retina, Pramod and Manoj, and also any suggestions from Madhavan? Any comments? Madhavan, Secretary of TNOA. Madhavan is not there. Okay. Any of the panelists, because I like Shruti's videos as well, would have put a lens, because normally what I do is when I remove a lens, I always put a lens as a scaffold into the bag and bring this lens up into the anterior chamber. Make sure that I use a good viscoelastic, a soft shell technique, both Hyalon and viscoat, and then cut this lens and bring it out. So how many of you would have done an IOL scaffold in the bag? Because I don't want the PC to rupture when I'm removing this lens.
Yes, definitely makes sense. That should be the only way to go.
Yeah.
Shruti, I just wondered whether you had your cartridge there was a problem with your cartridge. If you're having 2 consecutive lenses having a problem, that could be something to do with your cartridge, your IOL cartridge. So did you change it to the third case?
I changed it for each lens, ma'am. It was not the same cartridge.
Yeah, that's. I think one important message, because IOL related complications. I'm an expert in this because I've got the highest number of IOL related complications. Whenever you have a cartridge which is very tight while injecting, please don't inject that lens. Please come out. Okay. When you see that any tightness is there during injection, either a push technique or the what you call the rotatable technique, whatever it is, if you have any tight lens, please bring it up, because these lines are likely to get fractured. Either the optic is likely to get fractured or the haptic is likely to get fractured. We don't have much time. We have Pramod and Manoj there to comment on the retina case of Dr. Madura Gopal, and let's see what they have to say.
Manoj, you go ahead.
Pramod?
Yes, sir.
Manoj, yeah.
Manoj,
yes,
go
sir.
ahead.
Just 2 comments, starting with Jayantan's case. Wonderful managed though. But this technique of cutting vitreous going from pars plana route, first highlighted by Abhay Vasavada sir, and we are teaching and training and doing it routinely nowadays. Whenever you have even a routine case PCR, the only thing I would have done, or I would have advised to everyone, is never cut the vitreous blindly. That is one thing. You should have stayed just in the pupillary area. I saw your cutter going behind the pupil. That is should not be done. The second thing is that don't cut vitreous if at all you want to cut vitreous without an infusion line. This is just a blind technique. You are just cutting the vitreous and coming out, causing more traction on the surface of retina. So even an anterior chamber maintainer, even a side port infusion cannula should suffice. So this is the second thing. You can do with one port, like that means 123 or 25 gauge port to cut your vitreous, but let some kind of infusion there in the anterior chamber, so the chamber is always maintained and the vitreous is little bit hydrated, not too much hydrated, so you're not causing any undue traction there. The idea is whenever you cut vitreous from behind or anteriorly, whichever route you approach, don't cause any traction on the vitreous. That should be kept in mind. Okay, and stay only in the pupillary area. You don't have to go behind the pupil. Coming to Madan's case, fairly well managed posterior segment complication. Again, one small tip is whenever you are injecting PFCL, make sure in your syringe you don't have bubbles. So always look outside into the syringe, as what we do for intravitreal injection. And also, most commonly, this fish-egg type of PFCL appearance comes with a faulty technique of injection. That means you are not applying, adequate force. Force has to be uniform. You cannot just compress and decompress. And then whenever you have a fish egg, try to be in the PFCL bubble. Then and there itself, you can withdraw a little bit, like suck a little bit of PFCL and make it as a one bubble, and then try to avoid these kind of complications. I agree with you that interface causes too many reflections, but PFCL can be withdrawn in the same syringe little bit and again re-injected at the same time, and fish egg of PFCL can be avoided. So these are small tips which you can overcome very easily. And your videos were excellent and the surgeries were done quite well. Thank you so much.
Pramod?
Yeah, very good, very good. Yeah, very good video, like a surgeries, Madan Gopal, congratulations for that. Why we need to know about this fish egg, more common you see nowadays is basically IOP compensation machines we are using. The moment there is a little bit fluctuation, you have extra jet of fluid coming through your infusion line, and that creates a turbulence and you have multiple bubbles coming up. So what you can do is, as far as possible, don't come out of the eye, maintain the pressure. But if at all you have to come out, again, probably wall cannula system would be better in this scenario. But if you do not have, I would suggest reduce the IOP, maybe around 20, and then come out, so that the turbulence will be less. You are less likely to land up in this turbulence and this fish egg phenomena. The practical difficulty I anticipate when you're using sandwich technique, the silicone oil on the top and like a PFCL down, it sounds fine, but probably experienced people like Dr. Mohan Rajan also will realize, I would agree with. So many times you see, when you feel the eye with the silicone oil, you see some muck-like thing coming on it. Why it comes, we do not know. Dirt-like thing, muck-like thing. Next day it clears. But sometimes if it's something like that form intraoperatively, it compromises your visibility significantly. You may not be able to complete your laser. Otherwise, I think he handled case extremely well. I think I don't have any other comments.
Yeah. Thanks, Pramod. I think a very nice message. I just want to, because many anterior segment surgeons, Pramod and Manoj And if Saravanan is also online, or Madhura Gopal, or the vitreoretinal Karthik Srinivasan, many anterior segment surgeons are now doing vitrectomy through the pars plana. They're putting a trocar and cannula. Jayantan did a very good job. What are the precautions they have to take before you put a trocar and cannula into the vitreous cavity? I want to know, because anterior segments, they don't do it routinely. You vitreoretinal surgeons are doing it routinely. So what are the precautions they have to take? What are the do's and don'ts before you put a trocar and cannula into the vitreous? Pramod? Pramod? You're online?
I don't think he's online, sir.
Yeah, Pramod, can you just tell me?
I don't think PP sir is online. I don't think
Yeah. Manoj, can you?
Yes, sir. As I said, it should be the norm actually. Whenever you have a PCR, even in a routine phaco surgery, once you finish adequate amount of anterior vitrectomy, don't try to go behind the PC. If at all there is some residual vitreous, you want to cut it. Pars plana approach is always better. We have showed this with a couple of wonderful videos in many conferences. And my only tip here will be a single port of pars plana is more than enough. That is the vitreous cutter which will go through that. But never do any maneuver beyond the pupillary margin, and stay in the center, and always keep an infusion handy in hand. That means your irrigation has to be there in anterior chamber.
Yes.
Irrigation, you never do that. And always use a diluted transmural from the anterior chamber so that you see the vitreous fibrils, whatever you want to cut. Never cause traction on the vitreous. Any slight amount of traction also will disturb the vitreous space, cause traction on the retina, and you will end up in more post-operative complications rather than treating this patient. So these are the two small tips.
Yeah.
Some of the precautions to prevent retinal tear is to use a sharp trocar. That is one thing. And then use a relatively good cutter, a new cutter. So sometimes anti-segment people keep on using blunt cutters.
Yes.
So blunt cutters tend to use a lot of on the suction settings for 20, 23, and 25. They start with 20, it's 150 millimeters of mercury, double it to 300, and double it to 600 for 150 for 20, 300 for 23, and for 25 it is 600. This suction you want to keep, and cutting rate should be as maximum as the machine can provide. The fastest cutting with the adequate suction, 150, 300, and 600, depending on whether you use 20, 23, or 25. These are some of the tips to avoid peripheral retinal tears.
And also, before you put a trocar and cannula, make sure that your anterior chamber is really tight.
The globe should be tight.
Yeah, globe should be tight. Sometimes what I do is I put a suture always and then put a trocar and cannula, because I don't want the put a trocar, because whenever there is a PCR, there's hypotony, and if you try and put a trocar and cannula, it can be really dangerous. Yeah. Ravi Shankar, you want to say something?
Nothing, sir. Quickly, by the time this discussion is happening and we are going to finish it, I request the judges to talk among themselves, all 5 of them, and send the results to you.
No. One by one, we can ask the judges. Okay, fine, no problem.
Because we need to have single result. So they have to discuss among themselves, and probably one of them can announce the results.
Yeah.
I'll tell you the categories quickly. We have best headgear. Number 1, prize category 2, best individual video presentation, and finally the overall best team. So let the 5 judges talk to them together, and one of them can announce the results. I mean, you can take it, sir.
Before that, the best headgear team, not the best headgear team. Okay, but I think Pramod is online there. Pramod, can you just make a quick comment on that before Pramod? I hope you got my question.
No, sir, because power went off.
Yeah,
please tell me, sir.
The question, because many anterior segment surgeons are now doing pars plana vitrectomy. Okay, for the vitreous, for the PCR and vitreous loss, and trying to remove the vitreous, putting a trocar and cannula. So I was asking, what are the do's and don'ts they have to before you went offline? So that was the question I asked.
Yeah, I think I agree what Manoj said. Actually, that's very, very important. Don't do anything blindly. Yes, one single sclerotomy you can do, but as you need to have same thing Manoj has repeated, I'm repeating again. If you do not want to do a second vitrectomy, at least you have AC mentorer or some infusion line running inside, otherwise globe will collapse.
Hello,
Yeah.
So be in a pupillary area. Try to do just anterior vitrectomy, clean vitrectomy, and ensure it's a sharp cutter and full cut rate, not like a 300, 400 cut rate or something. Now, even your anti-segment machine also, you have 2,500 cuts. So I would say use maximum cutting available in your machine and ensure, because what happens most of the time, you don't use those cutters that frequently. You have to, so probably you may not be sure whether it's working or not. Most of the time, all of us feel that anti-segment surgeon should not need that cutter intra-op. But ensure your cutter is see outside, cutter is functioning properly, sucking properly, and full cut rate, and just in a pupillary area and come out.
Yeah, very nice. I think we will come to the end of any other question sessions. Any questions from the audience? Niven.
Sriram sir asked one question, sir.
One last point to what PB sir said.
Yes.
VR surgeons won't think this is possible at all, but the pedal sequence should be cutting and then aspiration. A lot of phaco machines have aspiration first and then cutting. So you can't have that when you're inside the vitreous cavity. You can't just suck without cutting.
Yes.
Yeah, I agree with Sriram. A very, very important point, Sriram. Excellent.
Yeah, very nice.
The VR machines have that, but anterior segment machines have that facility.
Yeah, but
I agree.
No, so, Pramod, I wanted to ask you, do you think that pars plana vitrectomy was necessary in this case of Jayanthan, what he showed? Was it necessary, or could have just left it?
Well, if coming to this particular case, few pigments here and there, then I would not have done, because they will disperse and will disappear over a period of time.
Yeah.
There was no vitreous loss, only to get those pigments out. Then probably, if you say necessary or not, I would say no.
Yeah, that is what I want to take home message. So I think we have come to the end of the OPL. We'll take quickly the judges' remark, each one of the judges, starting from Dr. Madhivanan. Madhivanan, before we announce the results of this OPL. And Madhi, can you come online, Madhi, and say a few words?
Dr. Mohan, I would want to say a word once the results are over to the entire audience. Just one word, please.
Yes.
Yeah, we have our ARC webinar on cornea and refractive from 5:30 to 7:30 today. And my very, very warm personal welcome to all of you to be there if you can. Thank you.
Definitely, Chitra. It will be our pleasure to do it. And Madhivanan, say a few words, Madhivanan, Chief Judge, one of the judges. Where is Madhi? Madhi is on. Yeah, Madhi.
Mohan Rajan.
Yes.
You want me to read out winners and things, or you want?
I want you to give remarks about all the players. Your opinion.
Each player.
No, not each player. Generally.
Yeah. No. Basically, I will say that I would like to emphasize that the youngsters, like everybody else said, the youngsters. To name a few, Madana Gopal, Shruti, Karthik, and I mean, they all did a really wonderful job. I think it is high time that and it is just that we are going to be, as Chitra said, that we are going to be only judges and panelists. I think it is accepted. It is a thing of the year. Now, what about the results, Mohan? What do you want me to tell
we'll announce in a couple of minutes. Siddharth, and quick, one or two words.
Yeah, first thing is you have all made us to sit on the chair, okay, and be observers. So we become chairmen. And second thing is there was one person from Chennai team, SGR. எனக்கு ஏதோ ஆள் மாறாட்டம் மாதிரி தெரியுது. கம்ப்ளீட்டா மூஞ்செல்லாம் மூடிட்டாரு யாருன்னு I couldn't make out.
முகமுடி கொள்ளக்காரன் சார்.
ஆமா சார். இந்த மாதிரி தான் சர்ஜரி பண்ணி ஏமாத்துறாரு அவரு.
So I have to see his Aadhaar card to approve of his presentation.
Quick, thanks Siddharth and Tangavel. Quick. Tangavel.
Hello. Yes.
Yeah.
Yeah. I'm just trying to coordinate with the others and tell them what is the total.
Total. That is fine. I want some remarks about all the players. generally?
Beautiful, beautiful. Lot of learning. First of all,
Yes.
lot of things, what we are doing, what I've been doing, is all new, so new. And the youngsters, they performed well, very well. And the initiative taken by you and all the participants, very informative. I really enjoyed the full time learning and judging also. It's a little difficult judging. Everybody is nearly the same, same marks we are able to give. I was able to just put it like the columns like content, practice, innovation, time, video quality, and voice. All this we separated and I tried to give marks for them. It was nearly the same. Very difficult to judge, Everybody presented very well. Thank you, Mohan, for this opportunity.
No problem. Tangavel, we'll come back to you for this thing. You can announce the results. But before that, I want Dr. RDR's take on this. RDR?
Yeah, thanks, Mohan. It was like 2.5 hours of nice knowledge sharing and learning. I mean, what was good was we had a very well balanced teams with good 16 surgeons. As a result, we had very good videos, all of them being skilled surgeons. Everything was really good. And, it's a good learning and knowledge for like a 4-minute presentation. And what we are really missing is what we really experience, the thrill when we are being present live. Everybody being together, that is a real thing, we have been missing. But on the other, and also we had an excellent panel of panelists. I mean, all their contributions, the points they brought out from each of the presentations were again excellent, and a lot of learning. As equally we learned from the videos, we also learned equally from each of the panelists' contribution, and again. Also, to add to you, but you also contributed quite a lot in many of those things. And I'm very sure that it will be useful to all our members, who have been watching this program. I'm very sure that they'll go back with a lot of knowledge and pearls about how they can manage the different aspects of surgery. We covered everything from cornea to retina, macula, fovea, everything. Thanks, everybody. I thank all the presenters for the very excellent job they did, and also panelists for their wonderful review and contribution and points. Thank you.
Thank you, RDR sir. Paneer Selvam. Paneer. Where is Paneer?
Mohan.
Paneer is there?
Yes, yes.
Yeah, Paneer, please.
I have the opinion of my fellow chair, and really the youngsters have really done. And I really enjoyed the whole program and the discussion that we saw. And the special thanks to you and appreciation to you and Ravi Shankar for organizing things. So I think you can also plan for TNOA in a similar way. Thank you very much.
We are doing that. Thank you very much, sir. I think I just want to thank all the judges, because they are all giants in ophthalmology, and it's a great honor to have all of them on the same platform, the virtual platform of PAN OPL. And before, I think Tangavelu can announce the results, the first category of the best headgear team. Tangavel?
1 second, I'm just trying to compile. I'm talking to others.
They are finding out which team has given the maximum money for them. And
anyway, till that time, just I wanted to say thank you very much for actually allowing me to be part of it. It's an excellent learning experience, I think, and it's really, really very good initiative, Dr. Mohan Rajan and everybody. It's a nice to see, and nice to meet everybody here also. It's still at home, actually, reminding me my old learning days.
Thank you, Pramod, for contributing so much. And I think you are a great asset for all of us. And,
okay.
I think when you combine fun with the science, the assimilation rate is much better.
I agree with you. Learning is much better.
MADURAI team. Headgear Chennai போட்டிருக்கிறேன்.
Mohan, I also wanted to add, this was an amazing OPL. I've been in many webinars, but there was so much learned here.
Tangavel sir, அங்க mute பண்ணிட்டு பேசுங்க sir.
Mute sir.
Sir, answer out ஆகுது sir.
Tangavelu sir, mute sir.
Mute பண்ணிட்டாரு.
Okay, I think they are waiting for the results. They are getting a little confused, the judges, because they are seeing the bank balances. Accordingly, they will do it.
Right now,
the only thing, we really don't.
Madi, no, I just Tangavelu, are you
to you.
Sir, on your behalf, I would like to thank a couple of people who have been part of this PAN OPL. Can I?
Yeah, you can give the vote of thanks and then we can have the results. No problem.
Yes, sir. Yes, sir. I thought paucity of time we'll do that.
Yes, we can do that fast. Yes.
Very big thanks to each and every one of you for being part of this PAN OPL 2020. And the best part was sparing a precious Sunday morning. It's very important on a Sunday morning you spend time with your family, but you spend time with your ophthalmology fraternity family here. Thanks a lot.
Now it's Sunday evening.
Great efforts to Dr. Mohan Rajan for initiating this PAN OPL. Thank you, sir. You've been wonderful. You've been kind enough to have this meeting on and on every year, and great effort. Thank you, sir. I would like to thank the panel of judges for being so wonderful and kind enough to be part of this PAN OPL, and still they are calculating. We'll wait for them. Thanks, judges. And it's a great panel team we had. Panelists, thank you. Each one of you were very excellent, giving your suggestions, giving your inputs after every presentation. Panelists, hats off to you. Thanks for sparing your Sunday with us. And I need to thank the players particularly. So great effort, great work behind, and it's not easy. Let me tell you, everyone, for getting the panelists and the judges to accept for this PAN, it took only few minutes, less than an hour. But to get the whole gamut of players, it took 72 hours for me. Dr. Mohan Rajan, sir. It wasn't easy. So, but anyway, at the end of the day, excellent players. Thanks a lot. Hats off to you. I would like to thank the match referee, Dr. Nivian, who's been coordinating so wonderfully. Nivian, great job. Thank you. Still looking smart and style with your black tees. Thanks a lot. And I would be failing my duties if I don't thank Mr. Sai from Numerotech Technologies. They've been the backbone of all the conferences, particularly all happenings of TNOA. Thank you, Sai. And for today's show, I need to thank Mrs. Manjula Sai also for working efficiently to make this a successful meet. And thank Mr. Sundar from Rajanai Care, who's been working with us to make this program exclusively to come out so well. Thank you, Mr. Sundar. And lastly, but not the least, the viewers and the audience. And I would like Manjula to come back to us and say how many viewers and audience we had in Facebook and YouTube after the meeting. So thank you, audience and viewers, for making this a grand success. Back to you, sir. Dr. Mohan Rajan, sir.
Yeah, you've forgotten to thank the most important person, the Zivira Pharmaceuticals, Kumaran. Yes. Kumaran is the son of the soil, Chennai, but he is the big guy in Bombay now. Zivira Pharmaceuticals, don't forget Zivimox, Zivifresh, and the other one, the Nepabel as well as Envisa, which are all products of Zivira, and such a humble guys, Kumaran, and without batting an eyelid, is generated. I want remarks from match referee, Nivian Madhivanan, who is the strong pillar of TNOA. Nivian, I want you to say a few words before we go on to Thangavelu for the final results.
So first of all, thanks for this wonderful opportunity. Actually, I know we had so many difficulties to get all these 16 players speaking so flawlessly is not an easy job. So well done to all the people who had actually spoken and the referees and the judges. I think it went on very smoothly without any glitch, and all of them stuck to time. So that is another thing that the TNOA is getting towards is we're all sticking to time, and I hope we can continue this forward in our future conferences also. So that's it. Thank you. We're just waiting for the results.
I'm seriously amazed by the talent the young people are having in Tamil Nadu. Is something which is incredible. I think all the, especially Salem Stunners, the youngest team in the whole lot, and they've done so well. All the youngsters have done so very well. I think, as Madhi and Chitra said, we all have to retire now. So
please ask them to send some mango packets to us, sir.
mango with COVID-19 it will come.
Mohan.
Yeah, Thangavel, please come. We're waiting for you.
Can you pick up your phone?
Mohan, sir.
Ninja solunga, sir.
I mean, I was really impressed when I think the youngest of the group, Shruti Vaishali, how confident she was when things were going wrong on the table. You know, as we are all in the panelists, I think Mohan Rajan commented, Chitra commented, sitting down here probably 3 months later and looking at a video and saying this can be done, that can be done. It's very, very nice. But then when you're sitting on that hot seat, I know how, Shruti, I know how you would have felt. And I could see a father hitting his forehead. I mean, these are really tense situations for youngsters. And if you really are calm and composed and able to think properly, I think you can manage anything that comes in your way. Very nice. And Madana Gopal also, you did a really wonderful job. I saw your smooth surgery of both the anterior and the posterior segment, and I was reminded of the pre-retinal, pre-hyaloid hemorrhage that we had probably 20-25 years ago, and how it was managed. I think if you ask Nivyan or Nishant, they will send you some videos or some snaps. Mohan, you're ready? If you're ready, you can tell.
I'm ready, Madhi. Thanks a lot, Madhi, for your words. And I'm ready with the results. Thangavelu has told me the results. The best presentation or the best headgear team. Let me start with the best headgear team. Can anybody make a guess? Best headgear team goes to Chennai Kings. Chennai Kings. Give the big hand for Chennai Kings for the best headgear team. Particularly Srinivasan Rao was mentioned about the headgear, and his headgear was much better than his coaching. Okay, number one. Number two, the best presentation goes to Madara Gopal of Salem Stunners. Best presentation goes to Madara Gopal of Salem Stunners. And the best overall team, can anybody make a guess on that?
Madurai.
Oh!
No. Anybody make a guess again?
No guess. All were equally fantastic.
The best overall team goes to Salem Stunners. The Salem Stunners wins the PAN OPL virtual. And the trophies will reach them once the lockdown is released. I do not know when.
Mohan, you should give trophies to all of us.
Yeah. We are going to give trophies to all the players, all the participants, all the players. It's really a wonderful experience to have all of you. And thank you very much. Have a good weekend and stay safe, stay home, stay healthy.
Thank you so much. Have a very good time.
Thank you.
Thank you, one and all.
Thank you also.
Thank you, sir.
So much.
Thank you, everybody.
Adiyar sir, Madhi, Chitra.
Thank you.
3 cheers to OPL. Cheers to OPL.
Thank you. And a big thanks to Ravi Shankar. Ravi Shankar, I think we should all put our hands together. Ravi Shankar, who's coordinated the whole event so beautifully.
Thank you.
Okay, thank you, Ravi Shankar. Thank you. Thanks, Mohan. Yeah.
Thank you, sir. Thank you, sir. Thank you, sir.
Thanks everyone for making it a successful, sir. Thank you.
Okay.
We'll meet again soon.
Thank you, sir.
Thank you, sir.
The earliest, Mohan.
Beginning of the Tamil Nadu OPL, Tamil Nadu ophthalmic webinars. So we'll meet again soon, maybe in a couple of, next week or maybe 2 weeks from now.
Yeah. Thank you, Mohan. Thank you, Mohan.
Thank you, sir.
Thank you, sir.